Good morning again. We are now online. Good morning to everyone. Good morning to everyone who's online who have joined us. My name is Bongile Chabalala. I'm the National Chairperson of Treatment Action Campaign and also the General Secretary of People Living with HIV sector. It's nice to see you all here. Yes, all beautiful, all of you, and handsome others. We are here today to launch our KP, which is Key Population launch. And we have conducted the survey as the sector. And in this survey, we managed to consult or talk to 5,979 people. In those people, we had men having sex with men, people who are using drugs, sex workers, and trans people. So I'm not going to say much about this, but this report shows how are we doing as a country in terms of providing services to key populations in the country. Comrades and colleagues, let me just acknowledge partners or stakeholders who are here, which is the National Department of Health. I'm told that they are either joined virtually and here. We have PEPFAR in our midst. We have UNAIDS. I'm told that people living with HIV sector is here, and some of the leaders are also on their way. And I'm told that everyone is here. So you're all acknowledged, and we really thank you for being here. So we'll keep on acknowledging people as they come. And we also know that we have media. You're also welcome. We acknowledge you. So without wasting any time, colleagues, I will give to Ndivuo, who will tell us how the report was developed, what we went through. Comrade Ndii.
My name is Ndivo Rambau, and I am a project officer in the Ritshidze project. So essentially, I'm going to take us through how we developed the report. The new KP report has been developed using a combination of qualitative and quantitative data collected through a large-scale data collection effort with a team of more than 50 KP monitors. Nearly 6,000 surveys were taken, combining interviews with 1,476 men who have sex with men, 2,397 people who use drugs, 1,344 sex workers, and 762 trans people. Some individuals with multiple identities, for example, a trans person who is a sex worker or a sex worker who also uses drugs, engaged in more than one survey to reflect multiple identities. The quantitative data collection took place between August and October 2021 across 18 PEPFAR-supported districts in 7 provinces. All the demographics and districts are outlined in the report, and all Ritshidze data collection tools are available on our dashboard through our website. So now I'm going to hand over to one of our key population monitors. As we indicated that during our data collection, we basically identified key populations through snowballing, sampling, and compared to a facility-based sample. So we're going to speak to one of the KPs who worked with us, and he's going to just explain how the experience was, what was our methodology, and just what went into the data collection. Here you go, comrade.
Good morning, everyone. Hi, well, my name is Siboniso Sibisi, but my preferred name is Black Shase. And I'm a gender non-binary individual, and my pronouns are they and them. And I'm also a KP. Well, to take you through getting an opportunity to to do the survey for Ritshidze, and going all around provinces, driving all over around, finding the MSMs and trans people, and then we got a chance to ask them and find their challenges and the use of tools that the facilities are using. And so far, what I've found is that most facilities, they are not well sensitized. So sensitization is what is needed in most facilities, because first thing first, the first challenges that we get is misgendering. Most trans people are misgendered, and most of them it causes them not to come back to the clinic, or it's either they want to take their pills or anything, and that causes them to default most of the time. So those are one of the biggest challenges, that if at the clinics they can just find a simplest way of having peer educators who are well sensitized from the gate till to the clerks till to what nurses or the staffs, that will mean a lot. And also the discrimination, what discriminated against. That's one of the most thing that I've been finding from most of the MSMs and the trans people. On that case, and that was one of the biggest challenge, and the exposure foot as well. So when I was interviewing most MSMs, they couldn't come to the clinics or go to police stations, because reporting another man, if a man sleeping with another man, they find it as an issue. And then even when you address when they address their situation to whatever facility that they add, they just find unequal, and then they just turn back, and then that causes them most suicides have happened, and most attempted suicide from hearing on their side. And that's one of the things that we found within the facilities. And another thing is where there's shortage of the shortage of programs within the facilities, and those were the things that we noticed. Yeah, I think that's it. Thank you.
Thank you, Comrade Boniso. So just moving forward. Oh, technology. Technology sometimes defeats me. Okay, so now we're just going to give overall, like just a highlight of some of the data that we've collected and analyzed. So overall, 20% of key populations we interviewed were not receiving services anywhere. By province, the highest proportion of people not receiving services was in the Eastern Cape, and the lowest was in Mpumalanga. In the Eastern Cape, these data could point to the fact that the province remains one of the poorest and most isolated provinces in the country, with many challenges plaguing the public health system. In contrast, data collected in Mpumalanga focused more on urban communities of key populations. Key populations with more than one KP identity were the most likely to not be receiving services anywhere, showing that overlapping marginalized identities are making it more difficult to get healthcare. During sensitization trainings, healthcare workers need to also be trained on the intersectionality of key population identities and how these can combine to create different additional discrimination and disadvantage. Now, when we look at people who are accessing services, the majority of key populations interviewed by Ritshidze used a public health facility to access their health services rather than a drop-in center, a mobile clinic, or a private doctor. In fact, many KPs we spoke to are not even aware of drop-in centers, including 87% of men who have sex with men, 81% of people who use drugs, 74% of sex workers, and 83% of trans people. Those who are not aware of them often live too far away and cannot afford the cost of transport to actually access them. So the following graph basically is showing the percentage of respondents who are very satisfied with health services offered. So while most key populations we interviewed were using public health systems, facilities, the experience can be untenable because of ill treatment by clinic staff, ongoing privacy violations, and even denial of services altogether. As expected, based on the evidence collected, key populations using facilities had far lower satisfaction levels compared to those using drop-in centers and mobile clinics. While ideally all key populations would be aware of and able to access drop-in centers, this is not the reality for most KPs we interviewed. Given that public health facilities are the entry point for many key populations into the health system, it is critical to ensure a friendly, respectful, and safe and confidential environment for all key populations with services that cater to KP-specific needs. KPs who are treated badly, humiliated, who often fear for their safety in the facilities or even refuse entry will inevitably not come back to the clinic, be it to collect ARVs or even if it's for HIV prevention or to uptake any other health service that might be offered. We cannot abandon key populations who are not able to get to a drop-in center. These issues must be addressed to ensure that all key populations are able to access health care services and are not left behind in the prevention of HIV and reaching the UNAIDS 95-95-95 targets. So now we're going to hop into it, and our first group of issues are on staff attitudes at the facility. So by and large, Ritshidze data reveal that staff at public health facilities were less friendly and professional to key populations compared to drop-in centers and mobile clinic. This is consistent across all key population groups, with just 42% of respondents reporting that facility staff are always friendly and professional towards men who have sex with men, just 41% towards people who use drugs, just 42% towards sex workers, and just 46% towards trans people. For those not getting health services anywhere, a lack of friendly services was the reason reported by 30% of men who have sex with men, 26% of people who use drugs, 32% of sex workers, and 45% of trans people. When we move on to drop-in centers and mobile clinic users, the most common reason for not using a public health facility is also because the care is not friendly, as reported by 66% of men who have sex with men, 61% of people who use drugs, 55% of sex workers, and 64% of trans people. So this graph shows the breakdown of which staff were reported to be unfriendly and unprofessional in facilities. Clinical staff were most commonly reported as being unfriendly and unprofessional by all key population groups, followed by security staff. Key populations should not have to suffer abuse and humiliation to access HIV, TB, STI, and other health services. Unfriendly services drive people away from care, affecting their own health, as well as broader HIV and public outcomes in the country. Not only is this an issue of human dignity and respect, but keeping key populations in care is critically important, and given the disappropriate HIV burden faced. So where the attitudes of clinic staff have become unbearable, some KPs have stopped going to the clinic altogether, including for HIV, TB, and STI testing and treatment. Public health facilities must welcome all healthcare users, including key populations, to access these critical services. So in true Ritshidze style, we have got recorded stories which we have gone into communities to speak to KPs to understand and kind of get a sense of their experience of using the healthcare system. And we also have key populations in the tent who've joined us physically, who will also be giving some of their testimonies as how they have been treated in some of the facilities as well.
Leina la ka ke ka tlholo mosweu ke tlohile ka ya tleliniking ya Tlamelong ko Block B, Tlamelong clinic ko Block B. E ke fitlha kwa banka tsena mo tleliniking a nna mo tleliniking ba re a re tla o bona o na le file ka ntsha file number ya ka ba nketsetsa file ka nna ba ra ke lata ka bo past 2-4 ba re ke lata ta boa ga o sale so ka ne sokola tšhelete ya transport ene ka tswa ka robala mo ntle mo gona mo tleliniking ka ntlhalosetsa doctor o na le bothata bo bjana le bjana di-muscles tsa ka mo gotlhe di botlhoko I'm a drug user o palela ko ntshwara ko kry-a ditšhika tsa ka pele o mfelela pelo ba irang ba lwa le nna orae nna ke tla go bona ke re kgopela heleng ke rileng kry-ele ambulance nkise sepetlele a ra ambulance rena a rena bokgoni ba ambulance mo tleliniking mo mare re ke tla go kwalela pampiri letter ya gore o ye sepetlele a ra nna ntse a ira mo a skirile ka a sa mfa pampiri ya transfer ka lebakeng la gore ke mmotsa mabaka gore nna transfer a ke na batswadi sa mathomo a ke na tšhelete gore nka namela ka ka tikisa sepetlele ke kopa at least a nzamele transport ya ka mo sepetlele ya ka mo tleliniking gore ba nkise sepetlele a re bona a bona bokgoni ba yona ke tla bona gore ke ira bjang ke boe after bo 3 days o tla nzamela transport ba ka ya ka ntlhele ba mfa dipilisi ka tswa ka boa gae le bo past 1 past 1 gona mo a re monna re dila gona dinyope tse tsa lena di irang la te tlhaba-tlhaba ka dinyope ka di-syringe le te tlhaba ditšhika tse tsotlhe tse ga le sana ditšhika le mo matsogong ga le sana ditšhika le mo maotong nna re o tlhaba kae bjanong nna re nyako kore ko tlhabile mo gore ka o sane gore ke nna ko o bolaileng nkarabile ona ka mokgoo.
My name is Anonymous. I'm from a ranger farm. I'm a sex worker. And I attend the clinic at Straightforward Clinic at Orange Farm, Gauteng. I've got a problem with the nurses, doctors. They'll treat me so bad because I'm a sex worker. And it's very depressing me because I thought I was normal. Since, well, they don't see that being normal of mine. But then I don't like it. That's why I asked for help and seek for help because what I'm doing, I'm not doing because I want to, but because there's no jobs, there's nothing, and we no longer I'm in drugs. I hate my job, but I love it because it gives me food. I am educated. I went to varsity in UNISA. I completed my studies. I'm a teacher by profession. Um, I really don't like the treatment that we get around here in our clinics, even locally. The people who give you negativity. The clinics who attend me after they swear at me, call me names, giving me all those dodgy eyes they have. But then I told myself that if not what I do, what else would I do? Who else will give me food, money, needs, wants? I'm a human being. And the fact that they got jobs, it's nice. They should just say, God, thanks. But then they will neglect me as if I'm not human and I've got heart. So I really wish that I can get a proper service, proper good help, because I'm in drugs. So I'll have some pinch in my hands and then I have to consult a clinic When I get there, people just look at me funny. I've got short skirts, I always wear them. So, yes, my reputation, my personality, yes, I know it's going down. Already for the fact that they're swearing at me, calling me African names, Mahosha, I don't love that. And I thought that's where I could say, this is my place of safety. I'll go there and tell them I've been raped. And then they'll go like, have you been raped? Or just somebody came and not gave you money. They call it surprise sex. That's hurting. I went there for help, not only to take the guy to the police because I don't know him. He used a condom. That's so clever of him, and I'm grateful he did.
My name is Marilyn Monroe, and I stay at Node, and I'm Tata, and I go to Civic Center. It's a clinic in Tata called Civic Center. It's in Node. I go for art and stuff. I am a man who has sex with men, but a lot of people see me as gay, but I'm just a man who has sex with men. And obviously I'm feminine, and yeah. So my joys, I'll begin with the positive stuff, obviously, with the joys that I have with going to that clinic. I don't think I'll be happy about anything, but the fact that I'm able to get my, at the end of the day, I leave with my art, that it makes me happy. But the negatives are so many. The fact that their services are not very good way too. It's like, for me, especially like a gay, I will say gay person because that's what they see me as, since I'm feminine and I'm a male and everything. So I'll say gay because that's the lens in which they see me. So obviously for a person like me, getting inside the clinic is just, it's so difficult. And it's just like, when I enter, you will hear nurses and people that work at the facility talking and just like pointing me out, uchomi. And for me, the term uchomi, actually, it's a polite way of saying istabane, which is a gay person. So it's so uncomfortable because I don't know those people. I'm not comfortable with them calling me chomi, you know. It's like, why are you calling me chomi? And for me, it's derogative. For me, chomi is a derogative term for me, given that they use it amongst gay people, you know, to say to someone that they are gay. Because to a straight man, they'll never say chomi, you know. So they'll point me around, laugh around, you know, uchomi, you know. Sometimes some will even come up to me, you know, have those small talks, you know. So I don't like that stuff. It makes everything so uncomfortable. It doesn't make me to really want to open up about the help that I need. Also, I remember the first time I went there, I had to go to another facility. The first time like I went there to get tested, I had to go to another facility because obviously I thought I had an STI, but I found out that it was actually HIV, right? So when I went to go get tested to get screened for STIs, I went to the facility and I was not happy. Obviously, I didn't feel like I would be able to open up about my sexual practices, given that the environment that I was in and people just like, you know, talking to each other, amongst each other, whispering about me, because obviously I could hear that they are talking about, like, they're not trying to whisper, actually. They just want you to hear that they are talking about you, and then they start laughing, you know, stuff like that. So obviously when I got there, I felt really uncomfortable, and I felt uncomfortable about a lot of things, and I couldn't state my case, and I left the place, actually. Got tested in another place, tested positive, but unfortunately I had to go back there because it's closest to my home. So same thing continued for like forever, because it still happens right now, you know. Like I don't feel good going to that clinic. It's like, why am I even going there? you know. And sometimes you will even leave the clinic without art, but not me, but a lot of other people will leave without art, you know, because they will tell you, water is like we don't have water today, so we can't wash our hands, so everyone who's here today must come back tomorrow. And it's just like, how do you even ask someone who's on art to come back tomorrow? Because you are literally saying the HIV virus in your system must multiply, and you know, so that's what they do a lot. They will tell like maybe like 100 of people to just like go home, no art for you today, come back tomorrow, we don't have water, we can't help you, around like 1:30. So it is just not okay. So their services are poor, very poor. Nothing really makes me happy. But what stands out, obviously, is just like being called names in the facility. You know, like they will literally call you names. And omyozomva atichomi, omyova is it, hey, Stabani, you know, that one is a Stabani. And then you'll see them coming one by one. They want to see who this Stabani is. Ne? So that's the issues that I have with the facility so far.
Ikliniki engisebenzisayo ithusabuphilo kliniki. Okay, ekliniki yethu okay bakhona bonesi, but ngibona ngathi staff siyashota because manje every time masile lapha ekliniki uthola iqueue iningi njengoba sisebenzisa ama drugs. Okay, bese ngacela ukuthi lapha ekliniki maybe kube nomuntu ozoba basic kubantu bama drugs or kubantu abathengisa ngomzimba into ezinjalo asibose still. Ngiyasho I'm almost 8 to 9 years ngibhema ama drugs, but ekhaya kuze baze ngiyasho senina 6 years ngibhema bokhathi bazi. Ngisakulese still dala ngagcina noma ngikonsela ukuthi ngihlanganise leyo 350 leyo ngihambe ngekadokotela ngibhadale leyo 350, but ukuthi kunokuthi ngekliniki ngiyazi ukuthi angikho into engizoyithola. Sister ngiba nalento leyo, ngiba nama doubts ukuthi namhlanje ngiphethwe izinyo, mele ngiyokhipha izinyo, ngiba nama doubts ukuthi mangifika lapha bazothi udokotela akekho.
En clinic engisebenzisayo Thusabuphilo clinic. Actually ekliniki basibambezela. Though noma kuthiwa kunomuntu ogulayo bathathela isikhathi sabo, basaqoqa noma basadla kenziwa amatiye uthi ngasikhathi kunomuntu ogulayo serious. Yiyo nje inkinga mina ngibonayo leyo. Ona kuyangi-affecta kakhulu because unokubona umuntu ogula ngenye indlela uzoyena ubuhlungu ukuthi labantu laba bathi bafonela ambulance mara awuyiboni ukungena, basebhizi bona ngento zabo. Nayi ambulance thola ukuthi ifikela ngesikhathi sayo. Ukuthi ngabe ngine-choice ukuthi bengingayikhetha yona i-privacy because bakusebenza immediately ufika ngokuthi maybe uyakhokha maybe bill le, ngoba le ikliniki le yamahala iyasibambezela kakhulu. Mina bengaprefera yona i-privacy noma songayithiwa nje imali khona imali iningi kumele uyikhokhe lapho sengamani ngachuza yona. Futhi ngathanda ukuthi mawufika bakhona ukusebenza my sister ngesikhathi leso sokukhona abantu njengokuthi umuntu uphaka ama-ARV. Ukuthi mangiceda kubhalisa ngisazobhodela ngale mara ngisayohlala nangale sister. Anginakuthi mawufika ngalo uzawungena, usazohlala ulinde thola ukuthi eroomini lapho number 1 akunamuntu, yibo kuphela abo sister bayaxoxa and kunabantu abahleli ngasedulweni. Into engenza ukuthi angiphathi kahle. Kuyomela ngikhethe ukuthi ngitshela bani ngitshela bani because omunye uyomtshela ayigqwalise kanti khona ozomthemba umtshela iqine kuye.
By the time you get inside with the sister for the final consultation, still you will have another problems. Uzothola sister maybe angekho one in the consultation room. Kunamanye ama-sister or the staff members. It can be angazibona ba-categorizana kanjani. but awumthola one usukulaki if uzomthola one. During the consultation time, if uzomthola one, definitely there will be another staff member ongenayo, either another sister afika xoxa izindaba zabo while when you are busy with the consultation, no sister. Then during that consultation, definitely kuzoba na some of the things. I'm the member of the LGBTI group. So kuna some of the things that I encounter during my living that I would rather ask the health professional, good, if I encounter such the situation, what must I do? Niyenza kanjani? But due to the fact that akuna privacy, angiziboni ngiyi-one, including naye usister ngingena nje, akangiboni as umuntu oku-LGBTI. I'm wearing my foundation, my makeup. Uzothola buka ukuthi, are you really wearing your makeup and all that? So I'll still have to answer all those things. So I feel offended somehow because now I'm part of the country, South African. I feel like I don't need to explain myself to people. So on that matter, I feel like the Department of Health has to do something, has to intervene in this thing, because the Department of Health is the one who has employed ama nurses and all that. Finally, ibaphe training regarding on how to handle the people with LGBTI and all those kind of stuff. Singa encounter such the thing. Ungena ukhathele, usazophendula ama questions. Still, whenever you're supposed to ask some questions about yourself, still uba nale problem yokuthi uzombuza kanjani. I-attitude ayikho good i-attitude. They are like, we are here, siyasebenza la. So it's either you take it or you leave it. So it's not in a satisfactorily standard. I am really not happy. I am asking the stakeholders. It comes to an extent which ngizibuza ukuthi, how do they get graduated? Bafundiswa ini kanti if ever they will struggle to work with patients. I understand we are different kinds of patients, but if ever they've got the training, definitely they had to have the indlela abangasebenza ngayo ukuhandlisha ama patients.
When I went there to receive services, the nurse that was assisting me there, I went in Nikikopa medication for flu, which they didn't have. They believe in home remedies and all that. And then in addition to that, I asked for anosol. Now, nurse o batla go itse gore why o batla anosol? Anosol, basically, according to her, anosol should only be given to males. So why nna ke tshwantse ke batle anosol ke le mosadi? What am I going to do with anosol? And a whole nurse asking me that. So now I stood there and wondered, because I'm a woman, does this simply mean I can't have anosol? Now I had to educate her again. I had to explain myself for who I am, what I am, what I identify as, why I need. My problem was, why do I even have to go to that length as to explaining why I need anosol? Ke tlile kwa ke batla thuso, ke batla medical help. Give me what I need and stop asking me gore ke irang ka anosol. So now each and every patient who comes in a batla medication wa gagwe, for example, the ARV or whatever, o tlo go bujiwa gore o batlelang ARV. So that was the problem.
Kind of like delayed me back in times, because at certain times I would like kind of like avoid to go there and like not want to go, because I know the struggle of just like being there is just like horrible for me, especially. And the fact that I need to tone down and kind of like just not wear wigs and all that stuff just so that people don't ask me certain questions, it's sort of like defeating. Now I'm at the point where I need to call people to go get my treatment for me.
I'm a gay man. Man, ngihlangana challenge le. I'm HIV positive. Loko ni ta swi tiva a ni kume accident a ku ri 2013 so ni pfune hi friend ya mehe a tirha ka FAMSA se u ni teke hi fambe swin'we mina yehe a ni yisa tliliniki ya ka hina n'wamiti wa tliliniki se loko hi fika laha hi fika hi testa mina yehe se loko ni kuma swa ku I'm HIV positive se tinese leti tirhaka laha ni titwa va karhi va vulavula vanhu ku biha va hlaya status swa vanhu se hi nese leyi nga ni cheka hi vuye hi landza ka yona friend ya mehe a ku ri like a va tivana a fika yi kombela swinene swa ku swi helela ka hina hi ri 3 because tinese letin'wana tshama na to la ene mehe va ni tiva ni dume ene hi twa va vulavula vanhu va ku tala la tiko ra ka hina. Okay, from there ni boheke ku spenda mali ni ya ka doctor swa ku ni kota ku kuma treatment ya mehe koho ene ni yi xava until now from 2013 because i mhaka leswi ni nga swi kuma le tliliniki hi ku a hi khomeki kahle va vulavula status swa vanhu loko cheka va kuma swa ku i munhu wa so and then va vulavula swo biha like va hi sandza and hi ku ya ku ni ya ka ti-special doctor ni fanele ni xava xilo lexi a ni ta xi kuma free because i mhaka leswi tinese leti ti nga laha tliliniki ya ka hina ti hanyisaka swona hi ku swa ni chavisa a ni nge yimi etliliniki to be honest swi vula swa ku loko ni nga ri na mali ni ta fela laha kaya i mhaka leswi ni swi twaku swi humelelaka tliliniki ya leyi hina hi tshamaka ka yona ka N'wamito mehe a ni nge yi tliliniki mehe sayiti ra mehe ene ti-gate to tala a ti mara mina swi kota ku pfuna ti-gate to tala mehe ni kota ku ni va landzela tilupu ni kombela ka n'wana ri manager mehe i tirhaka swi vula ku loko mehe ni nga ri na tona vana va vana va koti ku tikuma hi mhaka ya treatment leyi hi kumaka N'wamiti wa tliliniki a hi totally ya chava hi mhaka leswi va behavisaka swona like va hi discriminate swi vulavula swa voho swa chavisa u nge yi.
The facility that I go to is Greenfields Clinic in East London. So as a sex worker, there's a lot of challenges that I face when accessing the facility and when I'm in the facility. Firstly, I would just like to say it's the stigma around sex work and people who are sex workers, because most people believe that sex work, it's something that is unreligious and it shouldn't be done. So when you access a clinic and then you go to the clinic, you find, those women who are churchgoers, who are very religious, and then they've seen you on the street working, and then sometimes you just go there looking like a normal person. I can wear my short skirt, I can wear my short trousers, anything that I wear, and already they're gonna judge you because they have this idea what people should look like. And then also for me, it's a bit of a challenge because as a sex worker, my work actually allows me to engage in sexual intercourse a lot. So sometimes I get a reaction from the condom itself. Sometimes it's just a condom bursting, or sometimes I just get a normal infection like any other woman. So when I go to the clinic to try to access like medical help because of an infection that I got, or of an STI that I get, they would actually say, why are you always coming here for infections? Like, you are always here for infections. Is it because of the work that you do? Because if it's because of the work that you do, then you must quit doing this thing that you do. They don't even call it work because they have a specific name for sex workers. They call us omakhosha and all those other names. But then the truth is, anyone can get STIs, anyone can get an infection like any other normal person would. Because I could be having sex with my boyfriend, I could be having sex with my husband, or just my partner. And then I would get an STI, I would get an infection. It does not mean I got the infection because I'm a sex worker. I got the infection because I'm just a normal person who actually engaged in sexual intercourse. And then there was this other time. So they were actually having a conversation after I told them, no, I'm just here for a checkup. And then also to do, I had an infection. So she actually said, no, you guys, you also gonna make us sick. I said, hi, but an infection is not something that you can get by touching me. She said, no, you guys are sleeping with our husbands. you guys are sleeping with our husbands, and then their husbands come home, and then they bring the infection to us. And then I was just like, okay, but your husband is the one who came to me. I did not go to your husband. There was this other time that they actually didn't treat me. They said they were out of medication. So they said I have to go and maybe come back the next week. But I was like, I work, my job allows me to engage in sexual intercourse, and I can't work with an STI. So I had to go buy medication. I had to go consult at a doctor, and I had to pay money for that, for something that I could have gotten for free at the clinic. I would say, for instance, me, I had an issue whereby a client got physical. So the client got physical, and then I had to go to the clinic, like, obviously. And then this other nurse, she just made up a story. They said, no, your boyfriend did good by beating you up, because you can't be walking around the street and selling sex when you know you have a boyfriend at home. And I'm like, but it's not even my boyfriend who did this. It's someone else. I said, no, we don't want to know, but we know if you can stop what you are doing, your boyfriend is not going to beat you like this. They did not prioritize my issue. They were like, okay, we're going to come back to you. They were calling other people first, even the people that came after me. I've never been at that clinic and got fair treatment. I've never gotten fair treatment. Usually when I go there, I would go there and then they'd be like, no, we're going to start with people who have serious issues. And sometimes I would get there in the morning, like 9 o'clock. I would go home very late, around 4 or 5 o'clock. And the people who came after me, they've already left, but I'm still in the clinic. And then that makes me lose out on working, because then I don't get to work that day. I know the word PrEP, but I've never been given information about PrEP, yes. So that's why I usually say you must take PrEP. Usually they say that why don't you start with PrEP, because I do a lot of HIV testing. And sometimes they actually force me to do an HIV test because they say I'm a sex worker. So as a sex worker, they automatically think, this one, she's going to get sick like very soon. So they would be like, no, you must do the HIV test first. And then when my test comes back negative, they say you must take PrEP. But I don't know what PrEP is. And already by the time they're telling me that I must take PrEP, already my mood is ruined because of the treatment they gave me. So I won't ask, what is that? I'll just say, no, I'm not interested. Because I don't have any information about PrEP. I don't know what PrEP is. So for me, I would say I would wake up in the morning and go to the clinic, but my mood would instantly change because of the discrimination that I get from the clinic, because of the treatment that I get. The nurses, they never treat me like a normal human being. They will always have to say, she's a sex worker, mahosha. So already when I go to the clinic, I have that idea with, okay, my day is going to be ruined already. Already I know that they're going to make a laughing stock out of me. They're going to be talking about me in front of others. Sometimes when I go to the clinic, there's people that I like stay with in the same community. And then who don't know that I'm a sex worker, because not everybody knows that I'm a sex worker. So they'll talk about, oh, mahosha and things like that. And then when I go back to the community where I'm staying in, there'll be rumors, mahosha, she sleeps around with our men. And now it's even a bigger issue, because it's not an issue that only stays at the clinic. Yes, it starts in the clinic, but then it affects also my personal life outside the clinic. So yeah, I've never gotten fair treatment at Greenfields Clinic.
Community stories that we have in the tent, I think we've got 2 or 1.
Greetings. I'm from Polokwane. When the COVID started, I'm normally having problem with my chest, and then I went to the clinic. When I arrived at the clinic, I registered as everybody else does at the clinic.
So the secretary le la mputsisa gore o bola ke then ka mmotsa ka re ke a go tlhola ka ba ka mmotsa ka re wa o ka mputsisa gore ke bola ke eng ka gore ke santse ke o tlhalosetsa nnese ka kwa gare.
At first, the security asked me what was I doing in the clinic, and I did say that I'm coughing, but I had a problem. I even asked the security, why are you asking me what am I doing in the clinic? Because I have to discuss that with the nurse inside, not you.
Gating.
When I asked the security why he was asking me why I went in the clinic, then he instructed me to wait there.
Then na tsena ka gare a fitlha bolela le nurse a bo ya re emanyana ka morago a tla bo ya re tsena.
And then he went inside to speak with the nurses, and he came back and said, wait a bit, and then somebody came to call me in.
So ge ke fitlha ka kwa tleliniking nurse ya mputsisa gore bothata ba go ke eng le ke be ke tswa sethitho ke go tlhola.
When I went inside the clinic, the nurse asked me what was the problem. I explained that I'm sweating and I'm coughing.
And a ntse ntšhi ka consulting room.
This happened not in the consulting room.
Ke mo batho ba dutšeng gona o mputsisa pele ga batho.
I was in the waiting area where there were other patients in the midst.
So a re go nna re lena le tlo re tšela di-COVID ditharakeng ka gore le makgosha.
And the nurse said to me, you, because you are a sex worker, you are a mahosha, you went to get COVID from the truck drivers.
Ntle.
And she told me to go outside.
Ko dula letšatšing COVID e nyaka letšatši ke ne ke dutše kwa letšatši o tla nthuša ka morago.
She said I should go sit on the sun. COVID needs a sun, so they will see me after the sun has burned me a bit because COVID needs some sun.
So ge ke dutše ka kwa ntle go tla nurse engwe ke a e tseba ke e mogolonyana ka kwa ka mmitša ka mmotšiša ka re ya kgonega gore ke beiwe mo ke ntle na ba re ke dule letšatšing ke se ka dula ka kwa le batho ka gore ke a go tlhola.
So when a senior nurse came, I know this senior nurse, and I asked her, is it possible that I can just be made to sit at the sun because I'm coughing?
A re a e kgonege then a ntše nkiša.
And she said, no, please come inside.
Ka bolela gape go nurse yela sanga ya ntsentšha ka gare o sa no bolela dilo mo pele ga batho.
So unfortunately, I went back to the same nurse who assisted me at first. She didn't put me inside the consulting room.
O bolela gana mo pele ga batho so a fetša re go o ya sepetlela. So ke rile ke
Okay, I was not taken to the consulting room. She was just addressing me in the waiting area. And then she gave me a letter. She said, I'm giving you a letter to go to the hospital. And in the letter, they were written that I've got COVID.
So ka ya sepetlela.
Then I went to the hospital.
E ke fitla sepetlela di-doctor di a makala di re wena a una COVID ba fetša ba tšea phone ba founela clinic.
When I arrived at the hospital, the doctors asked me, where is my COVID results? And then they took a phone and called the clinic.
Then nurse gona se ba fe answer sharp then ke ge ba no mpha di-allergex le di-pain block ka boela gae.
And then the hospital just gave me allergex and pain block and told me to go back home.
Ka morago ga taba e go dira
This issue has affected me very negatively because some of the community members who were in the clinic even wrote me on Facebook that I'm a sex worker.
le bana ba ka ba palela ko raloka le bana ba bangwe because of ba rile ke ne le COVID.
It also affected my children to an extent that they could not even go outside play with other kids because now they were discriminated.
Ke a leboga.
Thank you.
Thank you very much. Now we are going to talk about access refused at the clinics. Will be also led by Ndivuo.
Thank you, Chair. So now we're just going to touch on people who were refused access at clinics. Shockingly, significant numbers of key populations reported being refused access to services because of being a KP. This is absolutely unacceptable and goes against the Constitution. The highest reports of KPs being refused services were found in Limpopo across KP groups, a massive 38% of people who use drugs in Limpopo. In KwaZulu-Natal, there was also high reports of people using drugs being refused entry. For key populations trying to access healthcare, including HIV services, being chased away can make it more likely to deter future attempts. While some KPs were aware of drop-in centers and can find the taxi fare to travel to them, many aren't so lucky. Being refused entry to the only source of healthcare for you can leave you with no other option than disengaging from care altogether or attempting to be given a transfer letter to another clinic from the very clinic that refused you services. This means an additional travel cost to a clinic further away from you. This is a complete violation. All reports of KPs being refused entry to clinics or that services are restricted should be urgently investigated with swift corrective action taken to resolve the situation. So we have a few recorded community stories which speak to KPs being refused access in some facilities.
lebitso la ka ke Sello William Poshane ke attenda clinic mo Mabopane Bokonot office the nurses tse di bereka mo Bokonot office ke batsadi ba rena ba ba loreng fela ke batsadi ba ne le malapa ba ne but service ya bona ka mara clinic e phua and then rena ibile ba dinyaope a ba re bone bana ka batho gore tshila he ba re lebeletse mo bona because of o khona ho ya kwale o lwala officer o lwala ba 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 lapisa o itse ba ba tena ba wena sister mama chief sa di phone tse mo re tla re thusa mo tse di phone tsa rena di tsamaya wena sa ya ka tlhalanya re o utswetsa batho ba di phone o utswetsa batho ba o utlwa botlhoko ka nako tse o khopela gore ba o fe help e ba neng le yona ba kgone go thusa but ba gore ba o nyenyefatsa ba o tsela ko fatshe o tshila mo bona ke a ya tsene ke hekenela mathata like ke lwala ke tshwere ke something but service ya bona for site ya ka mkholoreng ke tsuba dinyaope ke khono tsena ke tlo nna mo reception ke nne bana di tseya wa tshehiwa ka mola a bana taba le wena wa lwala lo bira eng my private party e loreng ke ntsha moroto ka yona ke ona ne ke ne le bothata ka yona go khopela transfer ya hore ke khono ya kwa go oti ke thusitse ke family ya go hae go fitlhella ke be ke ya sepetlele gore ke bone hore clinic e wa tshwana o ka ya wa shwela ka mohare o ntse o ile clinicing because of a ba re tsele o serious a re selo mo bona we are nothing mo bona ba tsadi ba rena we are same blood e ba lo re ntse ba re tsele care but a ba re tsele care
go marara ntha o tsena like o tsena o bodile letsogo a banya go thusa gore ba o nyanya pele thomo ba botsa gore ape o utlwa botlhoko khopela dipilisi tsa dipain go botsa ka mkhono wena na ra o botsa gore o tlhabe matso wa hao o rutile ke mang thweo esikhalenyana mo tshantse ba o thuse a o fe ano fa cotton wool mola o te phumule maladi wa la o botsa phumula maladi ba tswa mo wena re sa stere bano a ke kre dipilisi nyana ba re a bana tsona gore ba re tshwara ka mkhomo ebile especially wena o ka tla ebile o tlhaba gane o betha syringe yo a bana taba le wena sister ba o nyanya 99 gore motho a teng o thoma go ditlhako a namelele le wena ya o bontsha gore a bone forget ka bona ba ka se thusi ka selo ba sa nthusa ba mpotsa gona ka mokhomantswa ke a boletseng ke no dena ke ya hae ke dena ke ya go chemisteng ya morena pilise 1
e re reka ka 20 ranta ka mo chemisteng yona ya mo ke 20 ranta e wana wisa ke khono e phatlola mohabe ke ire 2 piece fela re ke khono tshwara ke boroko sister na go kra le tso le dumbile ke le lekana a ke robala wisa le botlhoko na go le botlhoko thata le morong o ka se robale ba se ke wisa nna ke na ba nko ke lwa le lona ke te khamolla lona ke irang tot ebe ke ba shap e bile ke sthoke nana le mararan thora ka wa tshwana kwa wa ya ba ro
ke bile o imathata me sister ke phela go ona go tleliniking kwa mararan to gore ke tsana ba nyenya ma sister ba re nyenya ma sister ke le ke la intera molotong la left ora shuwe la ga le tola tracks you know tsuwa nyawo ko moholo sister bantu no ngabantu shima kama akibere ke kama sister dilongo awa single fool ya sensible kabo match ke pra wala mo tlile mo mara ntomo la pena infection ma sister botlhoko ma sister o le ke ntsele batho ma sister ona le ona ka mo ke lona o se le tla le mskin la le infelice la level la without le tlo bona mantswa ba nsanga mola yo pero que ntshinda arna molo mo ke lo bona ra ba respect ke motho mogolo kwa se lo bona
last year 2020 bengiya clinic bengiphethwe ngama-genital wards then ngafika lapha eclinic ke usister lona ngamtshela ngathi ngiyavula ngiphethwe isifo engasi-understand la ngaphansi wathi okay angikhumule ngalala leya bed yabo nangilala lapho wathi ukhona umuntu osalala ngaphandle kwekhondom kule sikhathi samanje nge-2020 usalala ngaphandle kwekhondom lisuka leswazini leniphethwe kule sifo senizozigcwalisa la South Africa mina ngathi mina cha hayi ukuthi ngilala ngaphandle kwekhondom maybe isifo lesidala sahlala ngikhani sivela manje ngisathi wathi asimncede umuntu ophethwe lokugula lokho hamba esibhedlela esikhulu bayokusiza khona ngathi mina esibhedlela esikhulu esikepu kona bangivumeni ngingangabi nena ngaseclinic wathi hamba nje esibhedlela esikhulu ngeke sincede wangangibhalela incwadi wangangibhalela ini ngancena-ke kuya esibhedlela esikhulu ngihamba ngaye epharmacy banginikeza omunye umuthi wokugqoba namaphilisi ngaphuza wona-ke ngaba right-ke ngeke ngikwazi ngiprefer vele ke epharmacy since vele sengigula vele ngepharmacy ngoba ngenyana lokuhlambalaza walabona silaphaya sometimes bakusiva umncane kakhulu yabo mabaqala lokukuthuka nje no abahloniphi awangeke uma isesiweka vele awunavele umosi akekho umuntu ongakuhlonipha umosi vele angeke abahloniphe bangabathi uyi-sex worker.
My name is OG. I'm from Butterworth, but currently staying here in Namtata. I work here. Okay, I had a problem in 2018, the time I was trying to apply for an educational job in one of the schools in Butterworth. Then I had a problem with one clinic in Butterworth, Gateway Clinic. We are required in that school to have medical certificates from the clinic. So I was going with my other fellow colleagues, or shall I say the other applicants. So we went to the clinic to get the certificates, but there was a problem when it comes to me and my gender, because my ID, what is written on the ID didn't correspond with what I was saying or I was telling them to fill to the form. So it became a problem, and I felt like very offended because of that. The problem was they refused to fill the form for me because of the gender. Because on my ID it's written female, of which now I'm a trans man. So they didn't understand, and I'm sure they never heard of a trans man, because I think they never got sensitization about these kind of things, and also including about the LGBTI community. So that was the problem, a very big problem for me. And the others that I was with, they got their certificates, they applied for the job, and they got the job. So I do think these public facilities need to get education when it comes to the LGBTI community. They need to be sensitized and educated.
Oh, now we will hear from our key population organizer, Nkensani Mavasa.
Thank you, Chair. We now move on to our second group of issues, which are on safety at the facility. The majority of KPs interviewed did not feel safe and protected from verbal or physical abuse, physical harassment, or risk of arrest at public health facility used. Only 35% of men sleeping with men, 34% of people using drugs, 50% of sex workers, and 42% of trans people felt very safe using the facility. Similarly, only 33% of men sleeping with men, 32% of people using drugs, 38% of sex workers, and 38% of trans people felt comfortable at the facility. For those not getting health services anyway, a lack of safety was one of the major reasons given by 20% of men sleeping with men, 17% of sex workers, and 20% of trans people. Of respondents using drop-in centers and mobile clinics, 26% of men sleeping with men, 20% of people using drugs, 22% of sex workers, and 13% of trans people responded as safe conditions as one of the main reasons for not using a public health facility. Feeling unsafe and uncomfortable at the clinic discourages KPs from going to access services, impacting the uptake of testing and prevention services, as well as undermining long-term adherence. KPs must not face verbal or physical abuse, verbal or physical harassment, or risk of arrest when using the public health facility. Any reports should be urgently investigated and disciplinary action taken where appropriate. Now we'll be going to the recorded community stories, and some of the people here will share their experience that they encounter when going to access the services at the public health facilities.
Ba be ba o gatisele ka security o bontsha gore a o trustiwa motho mo bona wa selo.
So my experiences, for Mina Eshola Clinic is that I don't get too comfortable because of there are many straight guys, and which they are mixed with the MSMs and the trans, and so some people are homophobic. You understand? So when you come in, then they look you with that eye that maybe like this boy girl or something like that. So that's the main issue. They affected me a lot because sometimes I don't get comfortable going to the clinic because of I know that there are many guys that are going to look me with that eye and they are homophobic. You understand? So I don't feel safe sometimes. But sometimes the nurses are friendly and all. But the only thing that worries me is that they should make a department only for MSMs and only for men, so that there won't be that thing of we being stigmatized and being called names when the straight guys are there. You understand?
Ngisebenzisa iShawela Clinic. Mina as an MSM eShawela Clinic, the services are okay, but then the thing is I don't get comfortable enough. I don't get comfortable enough because it's male dominated and it's not MSM dominated. At least if it was MSM dominated, at least I was going to be able to feel free and receive all the services that I need and want all the time. And be able to be myself and be able to showcase as an MSM.
The stories?
What? Makalemani. I'm from Clarksdorp, Northwest.
I'm from Klerksdorp, Northwest.
Yes, I'm using Mpelisweni Clinic.
I'm using Mpelisweni Clinic.
Okay, let me talk about safety first. You know what? I got ill treatment at the gate. It started with the securities calling me names. The other one called me Somizi. The other one said, no, why not Senzo? I mean, guys, a legend like me, Senzo or Somizi. No. Hello. I'm an MSM. I'm out and about. Everybody knows my story. Okay, I found 3 guys there and a lady. So they were supposed to sanitize me. So these 3 guys refused to sanitize me. They called the lady. The lady asked them, why are you not helping this guy? They say, no, this guy make us uncomfortable. Okay, I didn't worry. My main concern was just imagine a MSM, a young MSM like me, who is HIV positive, who needs service and a treatment, getting the same treatment that I got from the clinic. Do you think that MSM would go back to the clinic? No. Good people, I believe that HIV is not healing us because what I've experienced, people are not using health facilities because they're not getting services, good services there. Okay, I got help. That lady sanitized me, and then I went to the waiting room. When I got there, there was no one at the reception. There was only a cleaner who was busy with the files there. And while waiting there, she read out names. I think it was 10 files. She said, Millicent Sibote, Tsepo Makalimani, Tabo Mamang, you should know that the treatment is, the ARVs are not here today. I think she must come for the next appointment. So I felt that there was no privacy then. Our privacy were violated. Okay. We sat there waiting for service. When I checked, one of the lady was one of my neighbors. And they called me, and we were 5 in a consulting room. So that lady also came because she was curious, why am I there? She wanted to know what was my problem. So I didn't even disclose because I had STI then, but I couldn't talk to the nurse because of my neighbor was also there, and other people were there. That especially for MSM and people who are using drugs and transgendered. And then one of the experience that I got there was a transgender lady who sat next to me. And she was also called by the reception, actually the cleaner. She called her, and then she read out her name. And her name was Tabo or David something. That cleaner was so surprised. She even called others. They made a joke out of her. Do you think the same person would go to the facility? No. The same people who are supposed to protect us are the same people who are discriminating us. The same people who are supposed to heal us are the same people who keep us away from their facilities. So I think the department, all departments should help us and train the health workers. Because I believe that we should be treated with respect and dignity as possible. Thank you.
Good day.
My name is Debogo Padu. I'm originally from East Rand, Fort Flores, extension 28. So fortunately, I'm closely to two most hardworking facilities in my section, which are J. Dumani and Telemokherane Regional Hospital. 2019, it was the worst year of my life. I've never been sick in my whole entire life. So I was working by then. So apparently I fainted at work. Okay, but initially I thought I was drinking. It was out of the alcohol and everything. And then I was rushed to a hospital. And then I got to Telemokherane. And then I went to that area where you are being rushed. Emergency, yeah. And then when I got there, and then there were 3 doctors there, and then they were younger doctors, and then they checked me, and then they took me to a ward, and then a day later, and then I got discharged. They said I was dehydrated, and then I was like, okay, fine. And then, like, a week later, I got sick again, and then I had to go to J. Dumani. And then I consulted with a sister, and then I said, I'm not feeling okay. And then sister said, you know what, because of you already have a case with the hospital, go back to the hospital. And then I went to Telemokherane with a letter from the sister that gave me from J. Dumani. And then when I got to to Telemokherane, and then the security guards were not welcoming me properly because of how I dress and how I look. So they would say comments about my look and how skinny I am, and So every time I would go to Telemokherane, I would have to disguise, wear like a big hoodie and cover my hair, and I would not put on makeup and wear swaggy pants, like amateka angcolile, yabona, like look like a normal guy, so that I don't get silly comments from the guys who are at the gates from the hospital. So when I went in, and then the sister, I told the sister I was in the emergency room again, and then the sister, I told her that I'm sick, I don't know what's wrong with me. And then they checked me, and then I was lying in the bed, and then they didn't know what was wrong with me. And then they called a couple of young doctors, and then they asked me, what was wrong with you? Like, what did you do? And then I didn't explain. And then they were laughing about my situation until another Nigerian doctor walked in. I'll never forget her name. And then it was Dr. Chivu or something. And then she checked me, and then she said I was diagnosed with fistula. And then I was booked for an operation that year later, around September. It was earlier. And then when I went on the same day for the operation, after a couple of months being sick, because I ended up not being able to sit down. I was not able to sit down like this because of the the condition I was in. And then I went on that day, and then I told her I'm ready for the operation, and she said, no, you're not gonna die. Like, this condition, it just needs you to maintain it, and then in a couple of days we'll take you in, and then we'll cut it off, and then you'll be fine. And then I went for that operation, and then ngayenza operation ngaphola. Well, then I felt ngathi ngipholile, kanti abangenzanga kahle or something, and then it came back again. And then mangibuyela esibhedlela again, and then they started accusing me of I'm sleeping with a lot of men, and then I was not supposed to penetrate my anal. So I was not even able to confide about my sexual activities to the sisters. So basically, they were like telling me things that I'm doing, and I should stop, not advising me and everything. So I was not happy with the service, but I still go there. I'm still using the facility, and it's good. Thank you.
Thank you. Now we will be talking about confidentiality at the facility, and Ndivo will lead us.
Okay, so now we're going to touch on privacy violations amongst key populations who are using the facility. So our Ritshidze data highlights that significant numbers of key populations do not think that privacy is respected at the clinic. A quarter of those using the facility felt that their privacy was violated. Either their HIV status was shared without their consent, or being outed as a key population, for example. So being referred to as a sex worker, as a person who uses drugs, a man who has sex with men, or a trans person. In terms of those who are not using the facility in terms of privacy violations, for those not getting health services anywhere, a fear of exposure was one of the major reasons given by 27% of men who have sex with men, 18% of people who use drugs, 23% of sex workers, and 21% of trans people. And a lack of privacy was a reason given by 26% of men who have sex with men, 19% of people who use drugs, 28% of sex workers, and 35% of trans people. Of respondents using drop-in centers and mobile clinics, 49% of men who have sex with men, 53% of people who use drugs, 40% of sex workers, and 54% of trans people reported the lack of privacy as one of the main reasons for not using a public health facility. Going to move into some of our recorded community stories.
The other issue that I have is a problem because of sometimes when you come to the clinic, the nurses sometimes they chat while they have to attend to patients, and maybe sometimes you're being attended by a doctor, then the nurse is going to get in the home while you're busy with the doctor. You understand? So there's no confidentiality in that way.
No, my confidentiality and privacy, it's okay. I cannot say it's very good or excellent, but then it's okay. But then the thing is, it's a problem with male people. Obviously, they're obviously straight. So when you come inside the door, obviously they look at you somehow, not forgetting that obviously this facility is supposed to be MSM dominated. So they look at you somehow. Others, you can say that they're homophobic by looking at you. So I would say that by straight people dominating in the clinic, it's not really okay and it's not really comfortable. I can say it affected me a lot because obviously when you enter the facility, you lack confidence. You just lack confidence because obviously imagine a lot of straight guys staring at you. How are you supposed to feel at that time, knowing very well that you've came to a friendly facility, but then when you enter, it's not really friendly because of the straight people staring at you. They can improve it by separating MSM with straight people, because they are straight. Obviously, they don't really understand what's going on in the LGBTQI plus world. So I can say that there's a lot of discrimination and homophobic comments and homophobic judgments whenever they look at you. Obviously, you just feel that way.
It's bad in a sense of kind of like you hear things when they're talking behind your back, and especially nurses, they're so rude. They kind of like talk in front of your face, like them especially, and it's like you're not even in the room. It's like they're talking about an object that's just there, and they're discussing you in front of everyone where there's no privacy. It's like no safe space. And the fact that when I requested that to kind of like my folder to be changed, it became a process of kind of like everyone now knows my status, everyone, because my issue was being passed on to so many people, if you know what I mean. So now like so many people know me this way. I understand it's a shared confidentiality thing at work, at their workplace, but the data captures, the nurses and everything is just like so unnecessary. Like there's so many people I had to meet before my folder to be changed, and obviously they see what's inside.
Usually they say it in front of people. Let's say I'm inside, let's say it's a consultation room. I'm inside and then I'll be like, no, I have an STI. Then they'll say, but you were here last week with the same problem. And then you say, yeah, but okay, what can I do? And then they'll just go call the other nurses. You say, come look at this one. Last week she was here. That other day she was here. Every day she's here for an STI.
So now we're going for community stories.
Melang. Lina Laka Kimongezi. I am from Klerksdorp at Northwest.
In Northwest.
Okay. There's a time whereby I went to the clinic. So haki ya go clinic. Firstly, I must say there is no services for MSM people at the facilities nor at the queues. You'd find at times that you'll go to the facility, you'll wait for 3 hours before you get inside the facility and get assistance. So while waiting at the queue, you'll find that you know when people are talking about you and those nasty comments. So even the staff members won't even try and intervene or something. They would stand there and laugh at whatever those nasty comments would be. So there was a time I went at the clinic. So when I got there, I went there to test for HIV. Then I waited and whatever that those security guards were saying. The other one said, Ntate, khutsana wena. Then the other said, no, motho ha ese ntate ke mme. Then you find you don't have confidence literally because klare low self-esteem by diga. So how tsana go clinic ba o le ke ntate then o mongwe ba ke mme. So a gona gore self-esteem ka nna teng.
So I was very patient waiting at the gate for about 3 hours until it was my chance to come in, and the security said, "Sir, it is your time to go in." And the other one said, "No, this is not a man." And they argued about that, and that really dropped my self-esteem.
Ebe ke tsena mo clinicing, and then so go clinicing eo ke itse few people ba berekang go teng.
So in that clinic, I know few people who work there.
Ebe ke tsena, and then I met this other lady who was receptionist.
And then I met this lady that is a receptionist.
Ebe anthusa then ebe ke ya go kopana le doctor.
Then I got assisted. Then I was in the consultation room with the doctor.
So ha ke tsena, so this lady said gonna kwena gape.
Then the lady said, "It's you again."
Ke be ke re eya a ke go no itse wa re after 3 months ke boye gape ke tla go testa.
I said, "Yes." You said to me, after 3 months I must come back to test again.
So ke be ke mara ke re ke nna o kitlile ge after 3 months ke tla go testa gape.
And I said, "Yes, I'm here. As you said, I must come back after 3 months to take an HIV test again."
Ebe a re konna ke sho ntso sa robalane for di foot o robalane hela varlosi.
And she said to me, "I'm sure you are not sleeping around and just sleeping rough."
Then
having
ebe ke
sex."
tshega.
Then I just
So
laughed
ebe
it
an
off.
testa, then ha fetsa go testa ba re wa bona di results tsa go santse di le negative.
And then she did an HIV test and she said to me, "You see, your results are still negative."
Then a ba re konna HIV sometimes e gona go iphitlha.
And she said to me, "Sometimes HIV can hide itself."
So ke kopa o tle after 6 months, then after 6 months re bone gore is it still negative or go etsagalang.
And then can you please come back after 6 months so that we can see if it's still negative?
Then so ha ke ntse ke dutse go na le buka e batlatsang mo go yone, the long very big book yana.
As I was sitting there in the consultation room, there's a big book that they fill in people's name in it.
So sometimes ke understand gore ke taba ya di stats and stuff. So ebe ke nagana gore like I felt very uncomfortable because abambotsa gore ke go tsenye mo gay sex worker or ke go tsenye ko kae.
And then she asked me, where must I categorize you as a gay or sex worker or male or what?
Then ebe ke sa marabe then ke be ke msha mo matlhong. So there's this other guy ke my aunt o nyetse ko Gabone, so aba feta. So ha feta wa mmitsa gore zona ke kopa o tle ka mo, then zona ba tsena aba botsa zona gore motho o ke eng o.
So there's this other relative of mine that passed by the time because I was no longer responding to their question, and the person was called in to say, where must I put this person? Which gender must I write this?
And then ebe zona are why o sa mmotse. So I go ke sena monate nix at that time because ke feel gore batho ba ha bantse sentle why ke sa kry thuso, and then ke tswe ke tsamaye iseng gore ba nne ba mpotsa gore o sex worker or o gay or o guy because like abatla go tika those boxes instead then zona aba mra gore no when I like skip unto and then o mo thuse a tswe a tsamaye instead of on no mmotse dipotso tse dintsintsi.
At that time, I was no longer responding to the questions because I was very upset about all the other questions that they were asking me. I understand that they need to fill in, but I was not happy with the process.
Then ke tswa then aba fetsa go nthusa. So le ha o ntse o dutse mo roomong then ba le batla ba tsena ba tsa ba ba se ba se batlang during consultation ya gago le doctor ko it seems gore ha gona privacy at all go di clinic tsa rona.
And whilst you are inside with the doctor, a lot of the other staff in the facility will keep on coming in, taking whatever they are taking from the room and going outside.
And then ebe ke tswa. So le ha o ntse o tswa ko batho ba tla ba go makaletse ba tla ba go bathong chomi o tlile gape o no tlo go direng o no tlo go testa gape ebe ke re nana ne ke tle go testa gape and then ebe ke tswa ke tsamaya.
And even the other staff will ask you, oh, you came again, did you come to do your HIV test? So they will just be speaking publicly like that.
And then ebe ke tsamaya. So there's this other time whereby chomiaka o ne a kula ebe ke mo tsaya re ya go clinicing.
So there's this time when my friend was sick and I took my friend to the clinic.
So ha re tsena go clinicing ba re yo gape di gay le rata attention gore.
And when we got into the clinic, they said to us, yo, you gay people like attention.
Then nese ya ba re mo gene he bathong wena se bane bane o tlile why o no sane dipilisi no yana nkabe o se yana bone ka o kula.
And the nurse just said in front of people, calling my friend's name, why didn't you take your medication? See, now you are sick and now you were not supposed to be sick.
And then ba phonela ambulance e betla go retsa, then we went to go Tshepong hospital.
Then they called an ambulance, then the ambulance took us to Tshepong hospital.
So ha re tsena go Tshepong re tsene ko casual. Then ha re tsena ko casual e be ke tlatsa file and stuff. So re ne re emetse gore Chumeka kopane le doctor, then doctor a ba re no motho o re tlo go mo admit.
So when we got to Tshepong, I assisted my friend to fill in a file and then waited at the casualty for the doctor. And when the doctor came, my friend was admitted.
So ha re ya go di warding there's a porter ki that guy wa porter and then ki doctor o na tsama le nurse. So re ya go di warding. So ha re tsena go di warding nurse wa mpotsa gore so chomi re lisa kae go male or go female siding tshwantse re mise go warding efeng chomi e ya gago.
So as we are escorted to the ward, the nurse asked me, where are we supposed to take your friend, in the male or in the female ward?
Ebe ke mmotsa ke re marianong ha o mpotsa potsana ID kante yone ya reng because ya re mail why o sa motse o mo ise go di mailing instead of on mpotse dipotso tse dintsintsi o ntse bona go motho ke wa kula.
So then my response was that you've seen my friend's ID says male, why are you not taking her to a male side? Because
Then
you're busy asking me a lot of questions and my friend is not well.
ebe re tsena ko male siding, then aba admitiwa, then aba kry-a rest. So the following day ha ke ya go mo tlhola ka bo 3, ha ke tsena ke a ba dumedisa, okay chomi o tlo go tlhola mmatisi. Then sometimes chomi ya ka o tla be le toilet or o tla ba a ile ko shopong or somewhere around the hospital, a ba re mmata ga go hayo nana o se hayo o tswile o ile kae. And while ke sa ba botsa because nka be ke ba boditse if ever ne ke tlhoka thuso or ke batla go itse gore motho o ko kae.
Okay, so the next day when I went into the hospital to check on my friend, as I'm arriving, without even me asking anything from the nurses, they were already saying, Chomi, your friend is not here. We don't know where she or he went to.
And then ebe ke tsamaya ke ya go mo emela mo a nang le teng, then a batla from ko toilet a batla a ntumedisa, then re be re bua. So ha ntse re dutse mo, then nurse o tla ba atla, ke a bona ke nurse wa gagwe or what, ha a tsena ko rona a re Mati wa bona gore mata ga go taga mo wa mapa re ntse re mo tlhokometse, at least ya ga go tshwane.
What is mapa mapa? So as we are seated there, the nurse will just come and discuss my friend's health in front of me and saying, can you see your friend is getting better? At least we are taking care of her, and so on and so on.
Okay, and then ebe ya ba re thusa. So ke tlabe ke borwa ke kganya gore all the time ha ke ile ba tlabe ba nna le dipotsa gore Chomi o tlo go tlhola chomi ya gago, sometimes wa hola seneng gape o tla boa mara o mo re gore le ha ile ko bo menateng ko bo SS o mo go anatse ARV ka bo 8 a ikometse ka savana or whatever sa nwang ka yone. So ke tlabe ke borwa ke selonyana se se yalo.
So what irritates me the most is that they discuss my friend's health with me. They'll say things like, you need to encourage your friend to take ARVs, even if you guys are going outside to do whatever you're doing, even if you can use Savannah, which is the beer, to take the pills at 8, please. And they do not even know if my friend has told me about
So in
his health.
conclusion, ke batla gore ko di clinicing and re tlhoka staff se ile goreng they are educated or ba trainilwe gore ba nne to have equal treatment towards us as gay men. Ba re fe the respect that we deserve, the respect that we give to them, gore ba sa nne ba re botsa gore eng or eng, because ID are male, not unless nna ke tlabe ke re no, I prefer to be a female. So ba sa nne ba re botsa dipotso tsa gore no, male or female or whatever, re go isa ko wording effing. So they need gore ba re treat as much as le bone re ba treat ka respect. Thank you.
So my request is that the nurses in the facilities need to treat us with respect. They must stop asking us questions as to you male or female and whatever, even though they can see what is written on the ID, unless I specifically clear what I would prefer to be called. Thank you.
I live in Orange Farm. I attend Mbalentle Clinic, which is based in Drizzy 3. So 2 years back, which was the month was August, I went there because I had warts on my anal. So I had an STI. I went there. I got to the clinic and I went into the consultation room. I got a doctor. As soon as I got into the consultation room, the doctor asked me what my problem was. I told him, and I told him that I have an STI, and he told me that they don't test for it. Mind you, he did not even tell me that they screen for STIs. So I could say I was less knowledge with like STIs and PrEP, PEP and everything. So he actually called in 3 other doctors, and they were minor doctors. And he said he had like a private conversation with them. He told them that this is what anal sex does to people, you know, who have sex in the anus. So it was kind of embarrassing because the doctor who called 3 other doctors he said he's a senior and these were minors, and now he was being homophobic towards me still, and I let it slide. I just wanted to get the medication and leave. I didn't want any drama or anything. So what he did was he gave me a flu pack. And I still haven't used it. It's still in the house. I had to do my own. Okay. I had to get my own medication the way I got it, and yeah, that is my story.
Thank you. Now we are going for recommendations. The first recommendation is any reports of poor staff attitude, privacy violation, and or verbal or physical abuse, harassment should be urgently investigated by the Department of Health and disciplinary action taken where appropriate. Facility managers should be held responsible for unresolved issues. For facilities we report on here, the DOH should respond within 3 months with actions that have been taken. Any reports of services being restricted or refused should be urgently investigated by the Department of Health with the disciplinary action taken where appropriate. Unfairly discrimination against key populations and restricting people access to health services is unlawful under Section 9 and 27 of the Constitution. In February 2022, the Department of Health should issue a circular outlining that key populations should never be refused entry to public health facilities and refused access to health services. That all key populations should be treated in a friendly, dignified, and respectful manner, and that privacy violation, ill treatment, harassment, or abuse will be met with consequences. Department of Health should also communicate these messages directly with the security companies utilized. The Department of Health and PEPFAR should ensure that all clinical and non-clinical staff, including security guards across public health facilities, are actually sensitized on provision of key population-friendly services. This training should include consequence management, plus key populations must be involved in the implementation of these trainings modules. Post-sensitization training follow-up should take place to assess the quality of key population services provisions. PEPFAR should provide a full list of facilities where district support partners have trained and sensitized staff in the last 2 years, including how many staff of which cadre trained per site. Health talks on key population issues should be carried out at facilities led by key populations to sensitize the general community on key population issues. In COP22, PEPFAR should scale up support to 300 additional sites across 27 district PEPFAR-supported district for ongoing trainings and sensitization of clinic, including staff, including follow-ups. KP must be involved in the implementation of these training modules. In COP22, PEPFAR should fund key populations, peer navigators at all PEPFAR-supported public health facilities to support key population service uptake, referral, and improve long-term retention. In COP22, PEPFAR should fund key population-led community groups to carry out HIV and TB prevention and treatment literacy trainings and localized social mobilization campaigns. By December 2022, each provincial Department of Health must ensure a minimum of 75% of clinic committees in province should have at least one member of key population group on the clinic committee. So now we'll be led by Comrade Kenzani, who's our key population organizer on key population specific services at facilities.
Now we'll look at the key population specific services at the facility. KP requires specific services. However, often those services are not available at public health facilities. Ritshidze data collected at 351 facilities between October and January 2021 showed that 131 facilities provide services for men sleeping with men, 80% for people using drugs, 125 for sex workers, and 73 for trans people. 104 of the facilities monitored do not offer services for all or any KPs. However, when we follow up with questions around what these specific services are, it reveals that the services are not really on offer. So out of 351 facilities, only 131 said they provided services for men sleeping with men, but in reality, it was fewer. Only 83 offer lubricant, for example, and only 33 have outreach services for men who have sex with men. Out of 351 facilities, only 80 said they provided services for people who use drugs. However, in reality, out of those sites that they say they offer sex worker services, only 16 offer methadone, 15 offer overdose management, and only 7 offer new needles. Out of 351 facilities, 121 said they provided services for sex workers. However, in reality, out of those sites that they say they offer sex worker services, only 70 offer male condoms and only 83 offer PEP. Out of 351 facilities, only 73 said they provided services for trans people, but in reality, only 14 offer hormone therapy. None offer a full package of services for transgender people. And we must remember that this is the list of services for key populations that facilities say they are offering. The reality is often that far fewer services are actually available. So now I'll offer to you on the issue of condom, loops, and contraception.
Okay, so now we move on to condoms, lube, and contraception. So KPs often struggle to access basic prevention tools like male and female condoms, and especially lubricants, either because those commodities are simply not available at all, or key populations are questioned for taking them or refused access. Sometimes condoms and lubricants are just not available. Ritshidze data gathered in 362 clinics show that lubricants were only available in 29% of sites between October 2021 and January 2022. 63% of men who have sex with men and 43% of sex workers we spoke to who could not access any lubricant at facilities wanted lubricant to be easily accessible. So the graph that's showing on the screen now shows the breakdown of lubricant availability at the facility, with Mpumalanga and Northwest performing particularly poorly. Condoms and lubricants should be made available at all sites and placed in the toilets or other areas of the clinic where people could take them without being worried about seen by others. In most of the facilities that we monitor, condoms and lubes are often sitting where the security guard is, and a lot of people feel that they can't go and get those condoms because they'll be judged by either the security guards or even if it's by the gate. If people are queuing by the gate, it becomes very difficult to take the condoms. In terms of contraception, a significant number of KPs who wanted to access contraceptives were unable to get them at the facility. As with general population healthcare users, key populations also at times face stockouts and shortages of contraceptives at the facilities where their first choice or first option of contraception was not available. These challenges, as documented in the Ritshidze Provincial State of Health reports, also needs to be addressed to ensure that all people in need of contraceptives can access their preferred option. In addition, key population are at times refused access to contraceptives specifically because they are key pops. This is a particular concern and additional abuse facing key population and is also a challenge facing adolescent girls and young women. This needs to be resolved immediately. We're going to move on to our recorded community stories.
I would say condoms, yes, but lubricants, they are not there. And it's been some time now, more than a year, if I'm not mistaken. There are no lubricants.
You know, when you go there and collect condoms, they'll tell you they don't have any, which is wrong, and that's impossible. It's a government clinic. It's in South Africa. Your choice is for free. So it really gave me a lot of depression, I must say.
When it comes to lubrications, no, that's you cannot access that. It's very difficult to access it at gateway, but in condoms, you get it every like it's there, but no lubes.
When I was actually exiting the clinic. So because I know my work, I have to protect myself. I took condoms, like I took like 2 packets of condoms. And then this other nurse, she actually called me out in front of everyone to say, no, we know we're mahosha, but you can't take a lot of condoms. There's other people who need those condoms. No, I've never seen lubricants in any clinic. I've never seen lubricants in the clinic where I go to. In Greyfield's clinic, I've never seen lubricants.
I went there and Kibata, with my condoms, I asked for lubricants as well. Now the lady, yes, it was a lady. The lady nurse tells me, the condoms are already lubricated, so why do I even need the lubricant? And I could tell that she's not even aware that I'm trans or I was born male. So because basically or mainly lubricants are used gay. When I lubricant now I had to go back into explaining myself again over and over. And just there at that point, 2 nurses came in because she already called in those other nurses. They didn't even know what lubricant is. Why? People were now amused. Yo, Batung, so it was exhausting. I felt that it was exhausting and embarrassing also at the same time. You know, we undergo through so much, and more especially how about these services from Bone, go the Gateway Clinic.
Now we go for community stories.
Molweni, igama lami ndingu-Precious. Ndihlala e-Eastern Cape, Port Elizabeth.
I'm from Eastern Cape in Port Elizabeth.
Nam ke ndikhe ndaya eklinikhi
I once went to the clinic.
ndinengxaki ne-piles.
I had a problem with piles.
Ndafika ke ndangena ke kwi-consultation room.
I went into the consultation room.
And ndaripota that how I feel ngaphantsi.
Then I reported that I had some pain.
And then ke ngoku wathi umongikazi.
And the nurse said to me,
kwenzeka ntoni kutheni une-piles nje ingaba kanti niyalalana na?
and the nurse said to me, what's happening to you? Why are you having piles? So does it mean that you having sex there?
Zijonge mntanam ba umhle kangakanani ba unoba indodana.
Look at how beautiful you are, my son. You can be a beautiful son.
uThixo akazithanda ezi zinto niziyenzayo.
God doesn't like what you are doing.
Tshintsha mntanam indlela ohamba kuyo yeka ulalo ezimpondweni.
Change, my child, what you are doing. Stop having anal sex.
Like bendinga understand ba kutheni ezawuthetha olu hlobo kodwa ndiripote piles.
I did not understand why I was given that lecture, because I was there to report that I have piles.
Wathi ke mntanam ke uyazi ba urhulumente ke akasayikhuphi into ekuthiwa yi-aniso lapha eklinik fanele kuyozithengela wena.
And then the nurse said to me, you should know that the government is no longer providing anosols in public clinics, so you need to go and buy it yourself.
Okwangoku ndiza kunika iPanado qha for intlungu.
For now, I'll give you Panado just for pain.
Ndahamba ke.
Then I left.
Ndayothenga ke i-anosol.
I went to buy anosol.
Ngenye imini ke one of my friends ke besasincokola about into ekuthiwa yi-lubricant.
And then one day I was just discussing with my friend about lubricant.
Sibe nathi singekho aware that bakukho into ekuthiwa yi-lubricant.
We're also not aware about the availability of lubricant.
Watsho ke itshomi uba hayi tshomi kuba gentle kuba smooth kulaa nto i-right.
And my friend educated us and told us that if you use lubricant, then everything will be fine, it will be smooth, and you'll enjoy.
Wathi ke yena ke uyithatha edwise eklinik.
And my friend told me that he gets his at Duse Clinic.
Ndaphinde ke ndabuyela kwiklinik yakwaZakhele ndokhangela ke nam le lubricant ndinganayo ne-idea yayo.
Then I went to the clinic that I'm using, which is Zakhele Clinic, to ask for the lubricant.
Ndafike ke ndahoywa ngu-security wathi mandikhangele phaa i-condom wethu into ingathi i-condom.
And then the security told me I should search for the lubricant in the box where they keep condoms.
Andayibona kodwa ndathi yiyo le i-condom mos le yesiqhelo. Uthi laa mntu uba i-lubricant isentweni esilver.
And the security told me, look there, it should be inside there, it's like something silverish.
Like ndiyacacisela i-security ndithi ba into engathi silver zii-condom qha ezi ndizibonayo.
Oh, then as I was searching on the box, I said, no, there are no lubricant here, I can only see condoms.
Okay. And then ke ngoku ndade ndaxelela nomntu wase-reception ndikhangela i-lubricant wathi hayi asibi nayo uxolo loo nto ikuthiwa yi-lubricant apha kule clinic khayobuza kwenye iklinik mhlawumbi banazo na.
Then I went over again to the reception to ask if they have lubricant, and I was told, no, we don't have that in this clinic, go and ask in the near clinic.
Because like ndiyayidinga nyani.
Then I went to the next clinic because I was really in need of it.
Same thing ke clinic ke zinoko it's 5 meters away, you're 5 kilometers away.
Luckily the clinics where I'm staying, they're not very far from each other, so I went to the next clinic.
Ndahamba ndayetshangana clinic akho lubricant, ndaphinde ndaye New Bright akho lubricant.
I went to Shangana Clinic, there were no lubricant, and then I went to New Bright, also I could not find lubricant.
So zange ndide ndiyibone i-lubricant ezi clinic until ke kufika i-organization ene-lubricant esinika rhoqo ngenyanga.
I've never received the lubricant from the clinic until another organization that came in and they do give us lubricant monthly.
Konyaka pheleyo I think i-organization yayivalile around January. Was out of e-condoms.
Sometime January, I think the organization was closed, and then I ran out of condoms and lubricant.
Ndaphinde ndahamba ndaye kwaZakhele ndiyocela i-condoms.
Then I went to KwaZakhele Clinic to ask for condoms.
Bandichazela that ba iseyiveki i-condom azikafiki eklinik into ye-provincial so kwi-clinic zikhala ngecondom ba abakazifumani stock.
They told me that it's almost about a week. We don't have condoms. This is a provincial issue. All clinics around have the same problem.
Ndancedwa ke ba mandihambe ndiye tavern that day and then ke ngoku ndayifumana icondom ndingakhange ndiyifumane eclinic.
Then luckily I went to the tavern that day and that's where I got the condom.
Ndiyabulela.
Thank you.
Dumelang.
Greetings.
Ke tlo ba anonymous ne. Saka story se tsamaya so ke tsama clinic kwa Bokonot office.
I'm a patient at Bogonont clinic.
So nna ke ile ko teng ke batla go lokela loop.
I went to the clinic wanting to insert a loop.
So ha ke fitla ko teng I didn't know hore the nurse di tsebang story saka, but fortunately they knew hore I'm a sex worker.
When I got to the clinic, I do not know how, but unfortunately the nurses knew that I'm a sex worker.
So nteba mpuditseng yona ke lo hore ha ke tsena ka mahare, the only thing they did ke go seba ba tshege and then ba throw di tantrums polelo tse snacks.
So when I went into the consultation room, there were nurses there and all they did was like speaking amongst each other. They were laughing and like it was uncomfortable.
So the only person who could not huntusa bona they like never sanya ke huntusa, so ke konna huntusa ke a male nurse.
The nurses didn't want to help me, but then a male nurse came through and assisted me.
And then it's not comfortable lo go bolela le a male nurse because sometimes ho le mosadi hona le dilo tse o tlhong ho di bolela le nurse ya mosadi.
Although the male nurse did assist me with the loop, but I was not comfortable because I would have preferred a woman, because as a woman there are things that I wanted to discuss with another woman.
So ke sona story sa ka seo di le di lubricants he ke ya kilo di batla hona le dipolelo tse leng hore di a tswa, and then dilo tse tsotlhe di end up di fitla go community wherever o tsamayang go teng already hona le story ka wena, and then you are not free.
So even when I go to the clinic to ask for lubricants, the nurses will make remarks in the midst of the community, and these issues will end up in the communities, and communities also will then make bad remarks about you.
So Bogono clinic since ke ya go yona a ke so kry an organization or re kutlwa batho ba reng hona le organization e ka thusang batho ba tshwana le rena le the lesbians and gays. Obviously every time ho tlela ho tsena ka moteng barato rasa like ke batho ba ileng hore they discriminate batho ba ileng hore ba nyaka thuso ba ba sa tshwane le gender ya bona, or ba treat batho in an abusive way, not a respectful manner, and then ho end up o le ka moteng like you are not free at all, or end up o ya go di private hospitals, or end up o ya go di private doctors.
So I've been using Bogonont Clinic for some time now, but I've never seen or heard of any NGO in the clinic that assists key population people. And the nurses there, it's like if you are not one of them according to them, then they treat you badly. And most of the time I end up using private facilities where I have to spend money.
And then when overtla di condoms tsa basadi le di lubricants, they are always not there.
And every time when you ask for female condom and lubricants, they tell you they do not have, always. Thank you.
Thank you. Now we are going to talk about PEP and PrEP, which will be led by Nkenzani.
Now we'll look at PEP and PrEP availability. It is well known that oral PrEP is highly effective for prevention or preventing HIV transmission, as it allows people who are HIV negative to be in control of their HIV status. As such, it is a vital tool to support HIV prevention, especially among key populations at higher risk of getting HIV. However, despite this, Ritshidze data show that PrEP is not always made available to key populations in the facility. PEPFAR has committed to ensure that key populations who test for HIV are either linked to HIV treatment services or PrEP. However, our data show challenges in the implementation of this commitment. Positively, interviews with facility managers reveal that PrEP is available at nearly all of the 400 facilities regularly monitored by Ritshidze. However, availability differed for each key population group and was lower for people who use drugs. While covering a wider and differing set of sites, key populations interviewed reported between 11% and 31% PrEP coverage depending on the key population group. This could point to the fact that PrEP has been made available at the Sienza or Operation Putuma sites, but not more widely, as well as that key populations are not always made aware of and offered PrEP services. Interestingly, awareness of PrEP availability in facility was around the same level as in drop-in centers. However, across key population groups, about half as many people we spoke to were offered PrEP in facilities compared to drop-in centers.
Now we are going for community stories.
Dumelang.
Greetings.
Ke tswa ke le Northwest.
I'm from Northwest.
Nna ntho e nkirileng hore ke tlohele ho tsamaya ko tleliniking, ne ke tsamaya tleliniki ya Hebrone. Ntho e nkirileng hore ke tlohele ho tsamaya tleliniki ke ho irahetse ke di-incident tse ithu tse di rahetseng. Ya mathomo ne ke lo kopela PrEP and ke thusitse ke.
So what made me to stop going to the clinic? I'm using Hebron Clinic. So there are two incidents that made me to stop accessing services at the clinic.
So this other day niki le tleliniki ke lo kopela PrEP.
This other day that I went to the clinic, I went to ask for PrEP.
Niki thusa ke mme o mogolo so.
An older woman who's a nurse was the one attending to me.
So elare he ke mo tlhalosetsa hore ke tlile ka eng putsisa hore e le hore ho irahetseng ke reipilwe na.
So when I told her that I needed PrEP, and then she asked me what really happened. Was I raped?
And then ka mo tlhalosetsa hore no a ka reipiwa ke nna ke batlang fela.
I told her that no, I was not raped, but I just want PrEP.
And mind you, monyako no le slightly open.
And the door was open.
Ke ha mpotsa hore ntho pila ba iretse for batho ba ileng hore ba tla ka di-incident tsa rape re ka se tsamaye re robala around re ra fetsa ra tla ko ditleliniking re tlo nyaka PrEP re ba bakela mmereko unnecessary.
Then she said to me that PrEP was actually meant for people who are rape survivors. We cannot go sleeping around and expect to come to the clinic. We are just giving them unnecessary work burden.
And then engwe e irahetseng ke he ne ke lo testa.
The other one is when I went to test.
Elare he ke tsena ne ho fetsotswa this lady he ke tsena ke kreile bo osi ba ne ba mo thusa ba bolela ka yena ka di results tsa hae and then ne ba tsheha.
So when it was my time to came in, I found the nurses were discussing the lady that just came before me, and they were discussing that lady's results, and they were laughing about it.
And then uncomfortable.
And then that made me very uncomfortable.
Thank you.
Okay, thank you.
Sanbonani.
Greetings.
I'm Diva from Sekunda. I'm using Embalenhle Clinic, extension 19.
I'm from Pumalanga and Sekunda using extension 19 clinic.
A challenge engedibana nayo iqale kuma security.
I had a challenge when I was getting into the clinic, starting with the security.
Mawufika lapha ekliniki ama security aqala akubuze ukuthi uze ngani, fanele uexplainela ama security ukuthi uze ngani ekliniki.
When you arrive at the clinic, the security are the first people who asked you, what are you doing here in the clinic, or what did you came to do in the clinic? Then you need to explain yourself to the security.
And then ngangena ngaphakathi, I have to explain again ku consult la ngizoconsulta khona ku nurse.
Then I went into the consultation room to the nurse, and then I had to explain again.
Mangifika ku nurse ngizocela PPE.
When I went to the nurse, I told the nurse that I came to request for a PEP.
PEP.
And then the nurse asked me why I wanted the PEP.
I have to explain ukuthi ke I'm a sex worker. Ngidajukele condom, that's why ngifuna PEP and angiziva kahle.
So I explained to the nurse that I'm a sex worker, and during my sexual intercourse I had a condom burst, so I'm not feeling well.
And then waqala ukubiza abanye ukuthi bazongisiza, yena ngeke azakhona ukungisiza cause ukhathelwe yithi ama sex workers sizofuna PEP every week.
And then that nurse called in another nurse saying that she's tired about sex workers because we come into the clinic every week wanting PEP every time, so she's not going to help me.
Nabafika bayi-2 bafika ne-cleaner bakhuluma discuss izindaba zabo, abasanginaki mina ngizofuna i-PEP.
So as the two nurses came in, there was also a cleaner there, and they were discussing their own issues and not attending to my request.
And then ngakhuluma nabo ngathi sekulate and isikhathi siyashaya and fanele ngiyolala ngikakalali.
And then I told them that can they please assist me, because now I have not slept last night, I need to go and sleep.
And then bangitshela ukuthi i-PEP ayikho, i-government ayisalethi ilona into zama-PEP lana angeke ngikhona ukusizakala.
And they told me that the clinic does not have PEP, the government did not deliver PEP for them.
Ngacela ama-condom.
I asked for condoms.
Banginikeza 2 yama-condom.
They gave me 2 condoms.
Ngacela lubricant, there was no lubricant at the facility.
I also asked for lubricant, but they did not have any in the facility.
That's all.
Okay.
Thank you. Now we are going to talk about harm reduction, and will be led by
Okay. So harm reduction services are critically important to support people who use drugs to stay alive and protect their health, including ensuring the accessibility of methadone and unused needles, overdose treatments such as naloxone, as well as psychosocial support and information on safer drugs. However, on the whole, these services are not available. People who use drugs are often judged and treated in a hostile manner. Ritshidze data shows that on-site drug dependence initiation and treatment, so for example, being initiated on methadone, was reported to be available by only 9% of people who use drugs using facilities, compared to 24% of drop-in center users and 12.5% rather, of mobile clinic users. This is less than a quarter of those in need. Unused needles were reported to be available by 3% of people using drugs using facilities, compared to 10% of drop-in center users and 8% of mobile clinic users. This is less than a quarter of those in need. Yet, people who use drugs want harm reduction services at the facilities. 61% of people who use drugs we spoke to would like an on-site drug dependence initiation and treatment for like methadone. 55% would like referrals for drug dependence initiation and treatment, in most likelihood methadone. 45% would like on-site drug dependence counseling and support, and service accessibility must be improved to ensure that the needs of all people using drugs are met and no additional barriers are created to being able to take drugs safely or supported to stop. Going to move on to some of our recorded community stories.
Tomorrow ba kopela injection a di teng gore ntong le ngwe gore a gore banya go bata ba lwena sa le ka ke lo tlatsa a consent form e tsela tsa di medical report o e tlatsa ba o checka nga gore kono ya rehab so kwa hantshi hertsen ren ba o tsor autor senyetsa nako ka ntho ya le tla hantshi lena ene ka male le rehab ba o jikisa gore a negotiate lwena jika ayo botsoro tabwane antsa asa kam ko bar tritan rena ns o grana go ngor chaba lo ya ditiniking na no chance ki le rehab ne to wa first time ya ke rehab ka sister na almost maybe 10 years ke tsu first time chance ke rehab so chance go tata that consent form onsa ntwe e rahetse vele chance go tata ko ampotsora usula ke to mosenyetsa nako ka di forms onsa ke bona o ke ditlatsa bjang then so mara ngwisa moya gore ka sithole ke nagana le gore go tlatsa di form ke a rehab and kamo ke tsuba di drugs ne
so wele ngepema idakamisi ezibizwa ngenyawupe so wele ukupemeni kwethu sinokuya ekliniki yethu elokishini siyocela usizo kangangokuthi sinokuthi sizibhede ngebhedi lezi banokuthi mabakumele basinikele ibhedi basiqoshe bathi lebhedi lezo azikho so wele aba street right ukuze njengabantu basithathisa njengwerwane into iwa angisazenzeleni clinic cha angikhona ukuya lapha khona ngiyazi ukuthi kumele ngiyocekwa mangifikwa lapho ngibizwe ngamagama amaningi so wena noma ngigula sengifela ngaphakathi ngibone ukuthi ngenza njani ngisisize
iclinic engiyisebenzisayo ithusa buphilo clinic ne okay mina nginokuya eclinic ngingasumuntu like ojwayele ukugula too much cause ngine problem nyana ukuthi ngiuse ama drugs wabona nokuthi asiya lapha eclinic siyofuna like ama injection wabona cause ohlala bakhuluma ukuthi ama injection akumelanga waphinde like ake wayuza thina sigcina sesiwaphinda cause lapha eclinic abasizi nganiki so wabo ukuthi awufika uzofuna like injection leyo bakutshela ukuthi no iniyekela lento lena yezwa uyofuna i-treatment lapho and then bazokutshela lento ezinjalo sigcina sesingasayi ngeke ngize ngisho ukuthi iclinic le ayiphathana right size sithola amanye like ebantwini baze bawadayisa umuntu owaphakayo lapho maybe ayibona usebenzisa like into zoshukela ngoba siyazithenga lezi zinto lezi which ukuthi isebenziswe lo muntu engamazi nokuthi ukugulela for ini yabo mina ukuthi ngiyaya lapho ngibatshela straight ukuthi ngisacela like injection ngiuze into ekaso I can't stop like that nje ngivuka kusasa ngithi asengiyayeka ama drugs without the help yabo angeke ngize ngithi bastreet good abastreet good uyangithola yabona like maybe ngiyagula ngiphethwe ikhanda bangitshela ukuthi ngithi ubhemele into zakho kakhulu uzoba right wabo ngathi batreata thina abantu like abayuza maybe these things of drugs like different rather than abanye abantu uyangithola njoba ngalangaza ukuthi at least basikhuthaze nathi sibe nama session nyana yabo like ukuthi awufikile uzofuna that injection ke bakuthathe bakubonise ukuthi this thing bakunike but bakutshela ukuthi wrong so but at least uzabe utry ngisho ukuthi nawe ube healthy bayabona ngithi ufuna izinto ezifresh wabo nethi sohlulwa ilento ukuthi addiction maybe bona bangakhona ukuthi bakusize ngicela ukuthi at least abangatry ukwenza lento leyo ba change lapho yabo bas treat like equal bangathi angifikile lapha ngikhala ngikhanda ngitshela ukuthi akabhemanga ushawa amadawuni wakhe uzoba grand hamba uyophuza amanzi whatever ngithola into kanjalo.
Now we are going to hand over to one of our data collectors, Millicent, on gender affirming and care.
Thank you, Dumelang. Gender affirming care at public health facilities. Ritshidze data shows that 10% of clinic users, we have 10% of people going to our clinics. And there's finding that our KPs are stigmatized and discriminated in facilities. That's why we have this percentage of our clinic, our 10% of mobile clinic users, and 7% of facility users, and 5% of drop-in centers. And some of our KPs do not know of drop-in centers. That's why we have a smaller percentage of that. And hormonal therapy is available to facilities, and most of our KPs and don't know about drop-in centers, and those who know don't get hormonal therapy in their facilities. Yet 58% of 58% response would like hormonal therapy at facilities.
Thank you. Now we have community stories or the recorded ones.
Another issue that I have is the fact that they don't advertise in terms of like getting hormones and all that stuff in that sector. They just focus on the male and the female. There's nothing in between, and there's nothing sex changes or anything. And it's a clinic. I mean, it's supposed to be, because they cater for everyone.
Thank you. Community stories.
Hello, my name is Shamila Mukwenas. I'm originally from Kimberley. I came here 2 years ago to Harrismith, relocated to the Harrismith province to come and assist for COVID and an NGO in Kwatwa. It's called Kolatko Advice Center. I worked there as an HCS linkage officer. The problem that I faced in Harrismith Clinic is that the sisters, when I go there for my hormonal therapy medication, and I did got my prescription and my transfer letter from my doctor back home. The nurse from Harrismith is an older lady. She tell me that, no, we don't know that kind of things, like a treatment, like what is hormonal treatment? So no, I was like, no sister, you're working here on Department of Health. How should you don't know about it? Because I will never let you tell you, I will never let to tell you that what and what and what. You should tell me what, because I'm telling you that here's my prescription, I need my medication to collect. So the sister give me bad attitude, like facial expression, I can see that, oh God, wow, what's happening here, Free State? Shut, yeah. Hi, I go back again, back to my room in Harrismith. After 3 days, I was heartbroken. After 2 days, I came back again to the clinic. I spoke with another white lady because she could understand Afrikaans much better. So I explained to her in Afrikaans because it's Sotho, like, I don't know Sotho too much. So the sister even now try to explain everything to the other white lady to understand me, get my point, trying to explain to the nurse that what we doing. The nurse suggests that I must take birth control pill. I say no. I will never take birth control pill because of I already started medication on 2019. So now I've got 3 months waiting for you guys to give me medication. I can't go back to Kimball and collect medication. It's too far. So no, what can we do because we don't know nothing about it. Okay, it's okay. I filed a complaint against those nurses from Harrismith. The cases have been waiting and waiting and waiting again. My contract ended in NGO. I worked together with them until now. I met with Ritshidze. Hannah approached me. Yeah, Hannah asked me like interview. We were doing like small group on a community hall in town. We exchanged the numbers. Hannah told me that I must come again. She will come back to Harrismith. After that, you might want to do some interview with me. I said, I don't have a problem about it. I tell her the whole story. Hannah make a follow-up to the Harrismith clinic, go to the sister, want to know the side of the story. Regarding my medication, why should I don't get it my medication? Until now, the case is still on, but I don't see way forward. I spoke to my doctors, send me the prescription and everything again. Right now, I'm collecting my medication from Clicks, and I'm paying a lot for that medication, guys, really. And most of the cases, especially in Harrismith, there are a lot of transgender females and trans men who need like medication, who really in need of that medication. And that for them to get medication is like to go to Bloemfontein, and it's gonna be like money and food and also shelter. Because one of my friends in Kwakwa, she was there in Bloemfontein, from Kwakwa to Bloemfontein. They take her back again. She was sleeping at night at a garage, bathing from the garage. It was painful, calling me all night, my friend, I'm scared. Okay, my friend said, no problem. Again, tomorrow, you get medication. I say, oh, it's okay, I'm at work now. At work, when they find out I was wearing my uniform, they see that, oh, you're one of us. I say, no, whatever you are doing, guys, is wrong what you are doing. Because of you're working with the community. You're the healthcare. So why should you act like this? Until now, there are some people who don't like communicate at work, really. Just passing a greet in the morning, just going to do my job. After that, going back to my room. I thank you.
Thank you very much. Now we'll go for recommendations. From February 2022, the Department of Health should begin a process to be completed by April 2022 of designating at least 2 public health facilities per population per district to serve as key population designated service delivery centers. Site selection should take into account local context, and facilities may serve more than one population, but it may not always be appropriate to combine all key populations into a single settings, given differential needs between key population groups. These sites must be allocated additional staff and resources to provide comprehensive health services to the specific key population being served. The Department of Health and the PEPFAR should ensure that condom-compatible lubricants and both male and female condoms are easily available at all public facilities, not upon request or in public spaces that make it difficult to pick up. The Department of Health and PEPFAR should ensure that harm reduction services, including medically assisted treatment such as methadone and other drug dependence treatment, are made available at public health facilities, and that trans people are able to access hormone therapy and gender affirming services closer to home. Where people who use drugs or trans people need specialized care from a drop-in center or public health facility offering specialized care, easy referral and adequate resource should be provided, including planned patient transport, money for transport to uptake those services. In COP 2022, to improve psychosocial support and counseling for key populations, PEPFAR should fund key populations to be employed as counselors. Now we'll be talking about drop centers and mobile clinic, which will be led by Ndivuo.
Thank you, Cheche. So next we'll look at attitudes, safety and confidentiality at drop-in centers and mobile clinics. So compared to public health facilities, drop-in centers and mobile clinics generally performed better from the perspective of all KP groups in terms of service acceptability and service availability. As expected, key populations using drop-in centers and mobile clinics had far higher satisfaction levels compared to those using public health facilities. However, there is still room for improvement to ensure friendly, safe and confidential services, and to ensure that KP services, specific services are available. Mobile clinics had slightly lower satisfaction levels than drop-in centers. KPs report that mobile services are inconsistent and are not always accessible close to where they are staying, particularly those staying in rural areas or staying in areas that mobile clinics feel unsafe entering. Even among those satisfied with drop-in centers, the percentage, with the exception of trans people, only half are satisfied. However, most KPs we interviewed are not using either a drop-in center or a mobile clinic to access services. In fact, Ritshidze data shows that a very high proportion of key populations are not even aware of any drop-in centers, and overall, use of drop-in centers is limited by this lack of awareness. The lack of awareness is consistent across KP groups. For those who are aware of drop-in centers, the distance and the cost to get to them can be prohibitive and mean that KPs are unable to use them. For example, some people who use drugs we spoke to around eThekwini, who lived not as far away from a methadone site compared to those in rural areas of KZN, still said that the services were out of reach as they could not afford the taxi fare to get there and back on a daily basis. We support vertical programming like drop-in centers and think they should be scaled up. However, they are not a solution to the challenge of improving services of KPs. Public health facilities must also be drastically improved. Now we're going to move on to attitudes at drop-in centers with Kensani.
Next, we will look at attitudes, safety and confidentiality at drop-in centers and mobile clinics. Given that drop-in centers and mobile clinics are specifically set up to meet the needs for off-care populations, a more friendly and professional attitude should be expected. However, there are still improvements that should be made to ensure that all key populations have positive experience at a drop-in center and mobile clinics or other KP population service delivery points. For instance, only half of people who use drugs think that mobile clinic staff are always friendly and professional, and only 71% of sex workers think drop-in center staff are always friendly and professional. In general, most key populations felt safer and more comfortable at drop-in centers and mobile clinics. However, many key populations interviewed still did not feel safe or comfortable even at the drop-in centers or mobile clinics they use. People who use drugs in particular felt more unsafe and more uncomfortable using a mobile clinic than the public health facility. And some told us this was due to a fear of being arrested. While this is better than at clinics, there is a room for improvement to ensure KPs feel safe, comfortable to actually get services at the drop-in centers and mobile clinics. Looking at the graph of confidentiality, among the key populations, there are those who feel that there is privacy in drop-in centers, and there are those who feel that there is privacy as well in mobile clinics. Out of male having sex with men, 93% confirmed, people using drugs, 90%, sex workers, 83%, and trans people, 94%. When it comes to those who feel that privacy is respected in mobile clinics, among the MSM is 83%, people using drugs, 55%, sex workers, 84%, trans people, which is 78%. Again, drop-in centers and mobile clinics performed much better than public health facility and respecting people's privacy. However, again, this was lower for people who use drugs, who use mobile clinics. There should be an investigation into mobile clinics saving people who use drugs to understand the challenges.
All right, and now we're just going to focus on KP-specific services at drop-in centers. There is surprisingly low availability of condoms and lubricants at drop-in centers and mobile clinics. These are key prevention services that should be fully available at sites specifically servicing KPs. 59% of men who have sex with men and 55% of sex workers wanted better access to lubricant in drop-in centers. The bar charts on the screen here compare the percentage of key populations being offered PrEP across facilities, drop-in centers and mobile clinics, and their satisfaction levels. Many more KPs are being offered PrEP services at drop-in centers and mobile clinics as compared to public health facilities. And satisfaction with PrEP services is mostly much higher outside of the public health facility setting. This is positive. However, a significant number of key populations had still not been offered PrEP at all. KPs who test negative for HIV should be given information regarding PrEP and offered it to allow for improved HIV prevention. Also to note, people who use drugs seem more satisfied with PrEP services at the drop-in center, and sex workers are the least satisfied with PrEP services at drop-in centers. Now, when we look at low PEP availability, concerningly, PEP was not reported as being widely available at either drop-in centers or mobile clinics, with worse coverage reported by some key population groups than at facilities. This could be a lack of availability or a lack of awareness of services available. Both issues need to be investigated and resolved. Now, in terms of the accessibility of harm reduction services in drop-in centers and mobile clinics, on-site drug dependency initiation and treatment, like methadone, was reported to be available by 24% of drop-in center users and 12.5% of mobile clinic users. New needles were reported to be available by 10% of drop-in center users and 8% of mobile clinic users. While this is much higher than at health facility, accessibility is still low for these critical services that are necessary to ensure that people who use drugs can take drugs safely or to be supported to stop. In addition, many people who use drugs complain that mobile clinics were inconsistent, pointing to the lower satisfaction levels of satisfaction amongst people who use drugs using mobile clinics compared to other key population groups. Reasons given included that mobile clinics at times did not enter the areas that they stay, or as they felt unsafe to do so. If people who use drugs were employed to support those services and better link them to those the services are aimed at, it could improve service acceptability. In addition, at times, the only service reported as being available was needle exchange, whereas significant numbers of people who use drugs want other harm reduction services to be made available as well. Another challenge is that many people who use drugs feel fearful of being arrested if they uptake services without being addressed. And this will continue to undermine the overall provision of harm reduction in HIV services. Now, in addition, there are extra services that people who use drugs that they spoke about that would like these services to be made more available. So 49% of people who use drugs who we spoke to would like on-site drug dependence initiation and treatment like methadone at the drop-in centers. 41% would like referrals for drug dependence initiation and treatment, and 37% would like on-site drug dependence counseling and support. Now we're going to touch on gender affirming care. Our Ritshidze data shows that only 10% of mobile clinic users and 5% of drop-in center users said hormone therapy was available. However, the demand is there. 76% of respondents would like hormone therapy at drop-in centers. We need a drastic improvement in the accessibility of these services for all trans people who want to have access to them, not just those who are located in bigger cities. Now we're going to have a recorded community story, and then we have a few stories from comrades in the tent.
I'm a recovering drug addict. Ngisuka eMpangeni ngifike la eThekwini ngenxa yokuthi bese benefamily yami ngenxa yokusebenzisa ama-drugs ngibeya ey'ndaweni ama-clinics ukuthola usizo. Abanye abantu batshela ukuthi mhlampe ingoba bengathandi ukuthola usizo nomani, kanti indlela abaphatheka ngayo uma befika ey'ndaweni zakahulumeni ey'bhedlela bayacwaseka ngokuthi badla ama-drugs. Abanye uthola ukuthi bangcolile, abasatholi usizo ngokuthi bangcolile. Ngakwenzela nje example, ngake nomngani wami kusanda kuqala i-COVID nje siye eklinikhi ephethwe yi-flu. So ngathi asihambeni ngimphezele eklinikhi. Masifike eklinikhi bathi asingangeni, basibuza ngaphandle ukuthi yini inkinga yabo. Safike sachaza ukuthi uphethwe yi-flu kanjani. Bathi asingangeni ngaphakathi, basilindisa ngaphandle kuma-steps. Mhlampe sawuhlala 3 to 4 hours silindile ngaphandle. Ngisho abantu abafika emva kwethu basizakala, thina baze basisiza ngoba sekuzovalwa eklinikhi ngokuthi asingayindawo ngoba ukube kwakwabanye abantu babezodikila behambe. So ingakho abantu ababhema ama-drugs bengathandi ukuthi be-accesse ama-services ama-clinics, bengayi ema-clinics nani. So kuze kube ngcono la nje eThekwini i-Dennis Hali iyona engcono abantu abadla ama-drugs abaziyo ukuthi mebeya khona ngeke beze bekuthola ukucwaseka noma yini, bethole nezinto abayidingayo njengama-syringe abantu aba-injectayo, bethole nje usiza noma ngabe ulwana abalidingayo.
Now we are going for community stories.
Sanbona. My name is Mandisi Manzi, and I'm from Durban. Yeah, ngingasho ukuthi in the public health facilities, they don't take us seriously, and as PUDs, they don't even assist us accordingly. They always have a negative attitude towards us, especially to people who smoke in Wunga. Because most of us, I'll say us, most of us are dirty, stinking, and they don't like us. Just the minimum of us are like always clean. And I'll make an example, a typical example of what happened in one of Durban's hospital or clinics. I went there another day. I was ill. I think I had flu because my body was heating, overheating, and I was sweating with another colleague of mine who's like a roommate to me. And we went there. It's too close for us. It's like near YMCA. Till we got there, we went to the consultation room. Then we were sitting with all the patients there. And the other nurse said, we must like tell them what's the problem. And then as we were telling them that the story is like this here, and they just told us they can't assist us because they think we're gonna sell the medication. Just imagine, we're sick, we're going to need attention from the nurses. They just neglect us and reject us and push us away. That's so embarrassing in front of everyone that you're all gonna sell the medication. Just look at that. When we vied out the gate, the security on the gate there, because my colleague, my roommate had a packet that he was holding on his hand, they said they overchecked him. And I asked the dude, hey, why are you checking all this thing here? And he just said, people are stealing sanitizing inside the hospital. Hey, I'm a short-tempered person. I just wanted to bust his head off because he's giving us negative attitude. Just imagine, guys. And the only place that assists us at Durban is the Belhaven Harm Reduction Center, which is the place, it's like a home to us, people who use drugs. This is the only place that assists us, and we live in fear now because they are short of funds. I don't know what would happen if that program stops. And Dennis Haley too, as we were looking at the recordings over there, Dennis Haley is another place which the P-Woods normally go there and bath, eat, and get clinical stuff. But we're being rejected at the public facilities. And I'll say like TBK, HIV, it's where people, they get syringes, people who inject drugs. They get fresh needles from them and other things that they demand. And I've got another friend which he got infected on HIV because they were sharing needles. At that specific time, they weren't giving out free needles. So I think this world must change now because most of us want to stop drugs and we can't afford, because most of us, we come from poor families and we can't just go buy and we can't just demand things from other people. So it's better for the government to like implant something which will help, like methadone, for example, at those facilities.
Thank you. There's another one. What's my story?
Sanbonani. So my name is Lutando Wagankosi from Soweto, but I'm based in the Val. So my story is I had encountered on the nearest facility. So as a transgender person, I'm on hormones. So it happened to the center that I go to, they didn't have, right? Because they supplied by Bara. So sometimes they have a lot of shortage. And it's better for us as trans. The more struggle is on trans men because they now have to travel to other provinces just to make sure that they stay on their meds. So now they don't have, and then I'm told that I need to go to the nearest clinic, which I went there. And then I was told that no, just go to family planning, ask for Trefacels, they work very well. Cool, I went. So on my way, already I told my neighbor, because this was my first time going there, I have never, but I knew there was a clinic nearby. So it's my first time, so I'm telling my neighbor, excited, I need to go to this clinic, how is it? Because I'm going there for family planning, I need some meds. Tell me a bit of their stories. So me going there, I have this attitude in mind that I'm ready. So whatever you're gonna throw at me, like I'm so ready, I heard about you guys. So immediately when I get to the gate, from the security guards, I think it was like 3 or 4 of them that were sitting inside, and then next to them there's a lady that is selling. So I'm greeting, already the security guards, it was 3 of them and 1 lady, their eyes are popped up, starstruck, you know, an alien came to South Africa. So now I'm like, okay, I am here, where do I go? I'm here for family planning. And then now the one security guy goes out, she comes back with the lady that is selling there. And then the gentleman asks me, so you say, what are you here for? And I'm like, family planning. And then like, family planning. And then now they start laughing, right? So the lady comes and then she looks at me, she greets me, and then she smiles and walks away. So I'm saying to this, then this guy says to me, no, it's already late. And I'm like, what time is it? And it's like, she was like 2:30. And I'm like, so why are you telling me that you guys are closed? You know, and he says it's a Friday, so it's short days for us. And she was like, oh, but then you can go try, because I can see you've got attitude, ne boot. Then I pause a bit, right? I'm wearing a mini skirt at that particular moment. I'm wearing a crop top, have my wig on, my face is well done. This is a person saying boot. So I just kept my composure, because this is an elderly man, and I've got this thing with Andino Pendul, I'm not going to respond to you, I'm not going to do this to self, you know? I'm too pretty for this, and I'm going to respect you as an elder person, I'm not going to respond. Then I go inside. When I get inside, the staff, everybody is there. By the reception, I'm expecting someone is going to come to me. And then all of them, they're like, hello, Chomi. And all the time when this greeting comes up, I always say, "Angsungu choma ngibeka amakeke." You know, I'm not selling anything. So I explained that I'm here for hormones. I was referred by my doctor. I showed them the documentation in black and white. They look at it, and then the other lady is asking me, so when wafunelani, you know, why do you want them? Because these are for women. So we are preventer, you know. And to self, okay, I was shattered. I got emotional, tried to keep my composure. And I said, but I have it in black and white. What is it that I have to explain? Because it's your duty in your department to know what I'm talking about. And then they're like, hi, girl, clearly I want to be pregnant, something like that. So they're all there. This lady's helping me here. So I'm on hormones and I'm on 3 dosages. So I drink 3 in a day. So now I tell them, because one cycle is 28 days. And I'm like, oh, okay, I might as well add that I'm on 3 doses a day. So this lady's like, oh, okay, so girls drink 1 and you drink 3. You know, why? So I don't want to respond to this. And I'm like, but then can I have am I going to be able to get the meds? And then they just, yeah. I'm having a question. The box is here, is full of the pills. Why are we busy interacting? Because it's written as in black and white. You get what I'm saying? So now this lady says, if we're going to give you like 3, and then the girls, what are they going to have? You know, because it's like we're giving you the whole box. Okay, right. My mood is down. I don't find anything funny, because all of these people are looking at the monkey, and everybody's got their huge smile on them. That's one thing that I really hate. It's like when you pass somebody of a different color, they pass you and then they smile. For who, for why? What are you saying to me? You know, what I'm using. So I take the pills. After taking the pills, the other one is like, let me know how they treat you. Then I went. So in that case, I felt that I was violated. I didn't have privacy. These are the people that are questioning my gender. How is it that you don't know? Because it's a problem for me when people, when they're wearing their uniform, they're so ignorant and they're blonde. And you see your colleague and then now you want to make mockery out of us. Because this is when we became mockery. Because now we in your community, some of you are your family members, are your colleagues. It's something that is there each and every single day. So how is it when we get to such spaces where we need to be saved, where we need to get the best service ever, people that should have a proper knowledge and information about all of those things, because you're dealing with different kind of people. Are you going to say to an albino person, why are you albino? You know, a disabled person can come in and say, oh, disabled, okay, why? You know? So that is something that you get to experience each and every single time. And I feel that we need the funders to start doing the right thing. We've sang our story. We've been doing the cry of help. How many people, how many queer people should we lose? We've been dying. We don't even have a hashtag, you know? But then nobody recognizes us. They say, South Africa, I always say South Africa is a beautiful country with a beautiful constitution. We're the first country that got the best rights. But still, we're being violated, and it's not only within the facility spaces. You get what, you go to any nearest police station, it's the same thing, you know? We mockery, people make fun of us, nobody take us seriously. You know, how are we gonna make awarenesses where we feel that our funders are behind us? They've heard the stories so many times. So what I need to find out from them, as you've been listening to these stories once and again, we've been saying, and these are the people that you know, you've seen us in the news, you've seen us you've seen us marching, you've seen our stories. So what are you gonna do about it? Why is it that we have to cry out so much and plead, but then you're still not taking us seriously? Can you respond to that? When are we gonna get the response finally to say, we've heard your plea, we have your cry, we understand what you're going through, can we implement something, and we're gonna start initiating it on this particular time? Our life matters as well.
Thank you very much. Now we are going for recommendations, and the recommendation are as follows. Any reports of poor staff attitude, privacy violations, and or verbal or physical abuse, harassment at drop-in centers, mobile clinics, or other KP services delivery delivery points should be urgently investigated by PEPFAR and the Global Fund, and disciplinary action taken where appropriate. For sites we reported here, PEPFAR Global Fund should respond within 3 months with action that have been taken. An assessment of service quality for mobile clinics servicing people who are using drugs should be undertaken given the low service acceptably and satisfaction found during the data collection. Health talks should be carried out at drop-in centers led by key populations. This should include information on prevention and treatment literacy, as well as service availability at the drop-in center. PEPFAR and Global Fund should ensure that a minimum package of services is provided for each key population group at all drop-in centers. Linkage of key populations from mobile clinics to drop-in centers should occur where mobile clinics do not offer a particular minimum service. PEPFAR and Global Fund should ensure that compatible lubricants and both male and female condoms are easily available at all drop-in centers, not only upon request or in spaces that make it difficult to pick up them, as well as mobile clinics and other key population service delivery points. PEPFAR and the Global Fund should ensure that harm reduction services including medically assisted treatment such as methadone and other drug dependency treatment, are made available at drop-in centers, and that trans people are able to access hormone therapy and gender-affirming services closer to home. Where people who use drugs or trans people live far from a drop-in center, adequate resources should be provided, including planned patient transport, money for transport, or uptake to those services. In COP22, PEPFAR should scale up additional mobile clinic per PEPFAR supported district to ensure mobile and outreach services in areas not served by a clinic and or rural areas. In COP22, PEPFAR should hire key populations to support the provision of mobile clinic service and outreach services. Acting as a bridge between community and healthcare workers, this can support better provision of services closer to where key populations are. In COP22, PEPFAR should increase key population programming to at least $28 million, matching COP20 and KPIF funding levels to improve the reach or consistency, availability of key population services. We thank you. This is the end of our presentation, and thank you for being patient with us and be with us all this time. Now, without wasting any time, I will ask our partners, especially the PHIV sector, people living with HIV sector leaders who are in the room, just to give us their reflections. Just 2 minutes, my leaders. I'll be very strict on time because I know when I'm dealing with leaders, we always want to talk too much. And I'll ask them to respectively stand up so that even people see them and give us their reflections. Thank you.
Okay, no, thanks very much, chairperson of the session, because to me, you are not the chairperson, you are the general secretary of the national sector of people living with HIV. Let me also acknowledge the presence on your behalf, chairperson of the session, of the chairperson of the national sector of people living with HIV, Comrade Mruleki. I've seen him here. Again, let me acknowledge, it will be injustice if I don't acknowledge the presence of people that made us to grow in this area of HIV. I've seen Comrade TD here. Comrade Andikolo, salute leadership. My name is Charles Maponya. I'm from Limpopo. I'm representing Positive Action Campaign. Again, I'm the national sector leader of people living with HIV, who is representing young men and young women and adolescents. That's the portfolio that I'm heading in the national sector. And it was not by default that I become the leader in the national sector, because if you can see, majority of people that we have heard their stories here are young men, are young women, and are adolescents. And it means your voice is going to be heard, because you have got a young person in a national level that is going to represent your interest, because I'm the youngest of them all in that sector leadership. And we want to put it on record that as the Positive Action Campaign, we are reaffirming our position to everyone who is listening and everyone that is here, that this sector is united. And from the report that we have received today, we are reaffirming our position that we feel like we have lost it somewhere, because our people continues to serve. Yes, we have managed to get treatment, people are getting our ARVs, but the treatment that they're getting when they have to access ARVs, how is it? So from whatever that we heard from here, from the sex workers, they must know that sex work is work. Sex work is taking children to schools. Sex work is providing for families. Sex work is making sure that each and every family is looked like a family. From the LGBTIQ people who are using drugs, we have heard your cries. And as Positive Action Campaign, as a member of the National PLHIV Sector Leadership, we are saying we are going to sit down. We are going to make sure we are going to hold this government accountable, because we are not just AIDS activists, we are human rights activists. Thank you.
Sanbonani. My name is Promise Memela. I'm from Positive Women Network, a national PLHIV. Thank you so much, my general. Hey, I'm very worried about this report. It shows that so much work needs to be done. And I'm so worried that stigma and discrimination is still here in South Africa after so much work that we did on people living with HIV. But now we are still need to work again. And as a Positive Women Network, we need to make sure that we are working together as the sector so that we can work, and this struggle, we will win it again as we won other struggles. And I'm sure if you are united as the sector, we will win this war together. Amandla.
Good afternoon, comrades. My name is Mluleki Zazini, the NAPO National Director and the chairperson of people living with HIV sector. I think let me first acknowledge the presence of IPEPFA and other partners that are here, and also to thank the Ritshidze team, especially the management, for organizing this accountability meeting for key populations. We really appreciate the work that you are doing. I'm saying this on behalf of the entire leadership of people living with HIV sector. Comrade Swangile, listening to these stories, it's so painful. And I think in some way it also trying to revive our activism, because we have dropped the ball. Without wasting time, because you said you only gave us 2 minutes, I think stories were presented here. Mine is just to say, as a leadership and the management of Ritshidze, these stories, we need to make sure that they don't end here in this platform. They don't end here in this platform. We have listened to a lot of recommendations. These are good recommendations, but these recommendations, they must not end here at this platform. We have a planned meeting with ETG of Health, because most of the issues, they affect the Department of Health. We have a planned meeting in February with the ETG of Health and the Minister of Health, including the Deputy Minister of Health. We need to hold them accountable, because this is a clear evidence. What we need to do as a leadership is to advocate. We need to make sure that we advocate so that they can do the right thing. I think let me also touch on what we are doing as Ritshidze. That currently, partly, I think, Comrade Bongile, the approach that we are using when our comrades, they go to facilities to monitor, being accompanied by our leadership at facility level. In some facilities it's working, but in some facilities it's not working. I think one of the decisions that we've taken, I think we were in Bloemfontein, that we need to have a desk in each facility where we'll deploy our comrades. And those comrades must be paid so that they can take that responsibility. So that a community, when they are experiencing these problems, they can immediately to go to that desk and report these things, and the advocacy must be done immediately on the spot. I wanted to touch on those issues. I know these stories that we're hearing here are so sensitive, and they need us to be cautious, and they need us to attend to them, because it will be a wasteful exercise to hear from these stories, but we don't act. So, comrades, we are inviting you to challenge us as this leadership to act on these stories. There are many platforms that are there within the country that I think eco population, we need to invite them. We have a global partnership to eliminate stigma and discrimination, and you are not there. We have a National Human Rights Steering Committee. Your voice is not there. So I'm inviting you to challenge us so that you can have a voice there and address issues that are affecting you. Thanks, comrades.
Thank you very much, comrades. The commitment is very grateful, and also for leaders to say we need to be challenged. It shows accountability. So without wasting any time, comrades, I will give to the National Department of Health to reflect or respond to some of the concerns raised here. I believe that it will be online. Leaders will assist at the back.
Good morning, comrades. Good morning, colleagues. I'm Dr. Sibongiseni Dlomo, the Deputy Minister of Health in South Africa. I am actually responding to a well-structured document of Ritshidze, Kasizulu Sisize, Awusisize, Save Our Lives. They have prepared a document, a state of health for key populations, and was given to me in January 2022. It's work that I've done in various provinces in the country, wanting to highlight challenges facing people with HIV, under NAPWA, TAC, the Positive Action Campaign, Positive Women's Network, the South African Network of Religious Leaders living with and affected by HIV. I then have prepared responses, having read the document. I read this document 3 times just to understand what a wonderful work that they have produced. But let me start in this way. There's a group of South Africans that we have put together, a 15 to 24-year-old, mainly females. In 2016, our President Cyril Ramaphosa, at the time was the Deputy President, launched a campaign in Pietermaritzburg, KZN, the campaign called She Conquers. The objective of that campaign was to do 3 reductions. 1, reducing sexually transmitted infections, reducing new HIV infections, reducing gender-based violence. There was also 2 encouragements, or 2 things that needed to be accelerated. 1, encouraging those 15 to 24-year-olds at least to finish matric, encourage them through programs of economic empowerment. Around that time, we simultaneously launched a campaign of the adolescent and youth-friendly services. We identified primary healthcare facilities and said in these primary healthcare facilities, we must have a champion trained to look after young people when they visit the health facilities. Today, just over 1,000 of primary healthcare facilities in our country, in a total of over 4,000 facilities, have at least one nurse trained in championing and prioritizing young people when they visit our facilities. Let me leave this narrative at this point for now. I will come back when I make some recommendations to the report that I've just been referring to. The findings of this report, which is well prepared, are saying that certain key populations in our country are not receiving services. However, I just wanted to caution, because sometimes in the statement it's just too general and not specific. For example, I had an opportunity to intervene when people with albinism reported that they do get services in our clinics, but however, they don't get enough sunscreens. And we needed, therefore, to intervene on this specific health need for people with albinism. So I just want to say, sometimes we need to be this specific. Yes, there are specifics in the document, but in other areas, it was like in this clinic at Chesterville, there are no good services. In this clinic at Vaihook, there are no services. Now, if we are not specific, it sometimes may not really assist in really getting good interventions. We do pick up that in the report, it is actually clear that the majority of our people, including our people in the key populations, do use the public health services. And therefore, we need to improve them, because that is the only hope. They have nowhere else to go. It's unaffordable to go to the private health facilities. We must be mindful, however, that the healthcare workers may as well be carrying the same picture that is there in our society until and unless we have good dialogues or training of our healthcare workers. Such prejudices that are there in our society around key populations will simply not just disappear because they just happen to be healthcare workers. They will carry that to them. So I think there must be a specific intervention of training. I'm not aware as yet of the effort that we have put in place as a society, as maybe through SANAC or the Department of Health, to train our healthcare professionals, healthcare workers, about the needs and the specific needs of the key populations in our society when they come and visit us in our facilities. I just wanted to mention one of the issues that come very strongly in the report, the attitude of staff, and actually indicate that the attitude of staff is something that we need to work into all the time. The poor attitude of staff to the key population is not unique to the key population. Generally, we do pick other citizens, other South Africans, when they go to our facilities, still complain about the poor attitude of our staff. So we need to complain, we need to continue to support, because here and there, there may as well be improvements. And here and there, maybe in one facility, it's not all our staff members who have a bad attitude, but one. But the impression is that when you leave that facility, you pick up the experience of what you have, and the experience of what you have was just that one staff member who had a bad attitude from you, starting from maybe in the reception, as the reporters actually make mention of that. I also need to caution and add this to the report, that there are specific interventions that you will not get available in the drop-in centers or in any clinic, specifically methadone for people who inject drugs and want to get out of that program. You cannot get methadone available in a drop-in center or a clinic because of its scheduling, and it needs a pharmacist and probably a presence of a medical personnel, which we don't have in clinics. Therefore, such a service may not be available at that level, clinic or drop-in center. Secondly, the hormone therapy for transgender people cannot be dispensed at the clinic or at the drop-in center. Such therapy needs to be done in a facility that may as well need a specialist to have. Clinics, however, still need to have condoms. They still have to have.
You have joined the conference.
They still have to have lubricants. I, however, note that some of the...
Hello? Hello? You have joined the conference.
Our clinics, however, should still be able to keep condoms, lubricants, ARV access, and PrEP. If you do not have these services, it's probably a logistical arrangement and tardiness of a facility, because this one should really be freely available in all other areas. I, however, note that some of the pictures in your report show empty condom dispensers in some facilities. Again, there may as well be too many other condoms still kept in a warehouse or the storeroom, but nobody is walking about in a facility to check that the dispensers are empty. I should admit, however, that there is no training or there is no adequate training of our healthcare workers to the needs of the key populations. When you pick up their insensitivity and the unprofessionalism in the report, you then say something needs to be. However, I want to mention again that there are certain, in the centers that you visit, methadone therapy, hormone therapy are not necessarily going to be available in all our facilities, and we probably need to accept that and know it will come with a bit of an inconvenience and travel. We may as well have to sensitize some of our healthcare professionals when they see a South African who picks up a condom and picks up a bunch of condoms, not to make them shout at them, say, why are you taking much more? Because maybe some of these people are protecting themselves against some of the activities and the work that they are part of. And therefore, the package of condoms, lubricants, ARVs, and PrEP should and must actually be available in our facilities. And we should talk about this abuse and humiliation of some of our people. I would therefore want to say, because we are mentioning in the report very extensively that public health facilities remain the entry point for most of our people on the key populations. And you are mentioning, however, that there are certain provinces where this service is better than others, that we need to really agree and target that we should focus on this process. I want to really make a suggestion as I conclude, that as I said, I scanned through the report and saw various experiences countrywide and things that needs to be corrected. I want to say we need to continue having a good service, a good attitude to key populations. I would want us to recommend the following, that maybe we should piggyback on the training that is there already of the youth zone champions, to be trained also to make primary health care facilities user-friendly to our key populations, in the sense to say, just like we have, for example, Sister Mlife in that clinic, we have Sister Zungu in the other clinic, who's a youth zone champion. We probably need to retrain them retrain them on programs that should be user-friendly to people, key populations. In that way, you'll actually be able to sensitize this facility and avoid the humiliation that you even talk about as you enter the reception. That when you're in the reception, a sex worker a client can come and say, is Sister Mulife in the clinic? And as soon as even the receptionists pick up that, they would know that you are a client of Sister Mulife. And in that facility, they need to be therefore referring you to Sister Mulife, who would have been trained. We come from the poor past, where a 17-year-old would have gone to a facility and asking to be supported for any medication. And a sister would say, but you are a 17-year-old. Why are you coming to us for family planning services? Now, those 17-year-olds come the next year pregnant, saying, I tried my best. I came to a facility and I found that people were not user-friendly. They were judging me. They were not ready to help me. I went home discouraged and never went back to the clinic. I was indicating to them that I am sexually active. I need their support. Can they give me? And they refused. Now I am pregnant because of that, what happened last year. And therefore saying we need to take that journey with everybody on the key populations to say, last year I came in here, I was HIV negative, I needed condoms. I know I'm a man who have sex with other men and I need to protect myself. But in this clinic, they actually made a laughing stock out of me. I left without condoms, I left without any support. But now we want to change that. And therefore I say, where we come from with the adolescent youth-friendly services is we are somewhere now. And we are not yet there, as I mentioned, that out of the 4,000 facilities in our country, only 1,000 have got fully trained youth zone champions. The other 3 are still also having the same process. I would want, therefore, to strongly suggest that maybe as a department, collectively with SANAC, with the civil society in SANAC, we look into a possibility of training and retraining our youth zone champions in facilities so that you do not necessarily get that facility, that help from everybody you visit in the clinic, but a specific nurse. As soon as you come to the receptionist and you ask for Sister Zungu, they will know that this person is a client of Sister Zungu, and the person wants to discuss his or her problems with Sister Zungu. I would really want to recommend that maybe we look into that and therefore explore that. That is my contribution, and I wish you well, and I wish that you can meet again and maybe explore this recommendation and see whether it can take us anywhere. Thank you very much, and have a good interaction in your workshop and meetings.
Thank you very much to the Deputy Minister, and let us apologize for the phone and the people. One day he was recording, he was trying to concentrate, and now, yeah, people, they just called and he was expected to join a meeting urgently. So, comrades, without wasting any time, I will ask a person from PEPFAR, I understand they are with us, just for a quick reaction and response if they do have. Noah? Where's Noah? Okay. Stories. Oh, okay. No, they are bringing a mic for you. Thank you.
Thank you. Good day to all. I am John Blanford. I am the country director for CDC PEPFAR. I was going to say a few words and I'll pass it over to Joseph Lawrence from USA PEPFAR. So I do really want to appreciate the effort that went into this for the survey itself, which I studied last night, but then also for the personal stories that really gave life to the numbers. The stories were quite compelling. I think it was very instructive for us to hear the comprehensiveness, what this looks like across provinces with respects to the attitudes of staff, the issues around privacy and respect for personal information, the safety concerns, and the access concerns. Hearing the issues around availability of key commodities, condoms and lubricants, the availability of PrEP and PEP services, gender-affirming therapy, and harm reduction services. So these are well taken and well considered. And I am struck, of course, with issues around attitudes of staff and the concerns about privacy and protection of personal information, that these are issues, of course, that we're also dealing with people's HIV status, the stigma and discrimination that comes around that. But this is a multiplier when we also have issues around KP status, that the issues around the attitudes of clinical staff, especially the clinical staff, that these really do undermine people's willingness to come and access the services. So these are well heard. I thank you too for providing this just as we're in the midst of our planning for the COP program, the PEPFAR COP for next year. I have to remind you that PEPFAR is just one contributor to the national HIV response, but we will take this seriously, and we actually have been, services for key populations have been prioritized in the COP planning level letter that we received from Washington. And so we are taking this seriously in our reviews and discussions to see what we can do to increase our commitment to key population services in the next COP that we're creating. Thank you for that. And but I do appreciate, I know how much work goes into this. I'm actually a technical guy before I became a country director, and so I know how much work goes into the quantitative component of this and how much goes into the qualitative component of gathering the interviews and doing the videos, and it's really helpful about how it all comes together to us. And we'll have follow-up conversations as well with our implementing partners within PEPFAR to follow up on some of the concerns that have been raised here.
Thank you.
Thanks very much. Hi, everyone. My name is Joseph Lawrence, and I'm with USAID here in South Africa as the Key Populations Lead. And I want to echo really many of the things that Dr. Blanford just said from the CDC side. Just a huge thanks for all of the stories that were shared today. And yes, the huge amount of work that went into preparing all of these stories and the data. Really, it's very striking to hear the powerful stories and great to hear a voice given to some of these marginalized communities and amplified, here in this tent as well as in the stream, and so many other places. I thank you. You've given many excellent points that we will certainly look to and follow up. As Dr. Blanford said, we are right in the middle of our COP planning process, so this is really great timing for us to take some of these things into consideration. We're certainly very much in support of the National Department's work, and we've been working on the KP HIP, the Health Implementation Plan, and are very excited about some of the new things that will bring to the individual facility levels. But as we go into COP planning over the next couple of weeks and months, we'll certainly have further conversations and see how we can utilize some of our PEPFAR platforms to increase these services beyond our specific drop-in centers. Obviously, we take very seriously some of the reports of inappropriate staff attitudes, specifically at our drop-in centers, and we would love more specific information so we can address those things, very, very specifically and very carefully. I think in the interest of time, I'm going to save some of the further conversations for some of the specific points. Just to say that we're very grateful for all of the work that's gone into this. We certainly hope to expand coverage of services through our PEPFAR program, working with our partners and friends at the Global Fund, as well as certainly supporting the National Department of Health. So thanks very much for the opportunity to speak today. We really are taking your points very, very seriously, and we'll incorporate them into COP planning over the next couple of weeks. Thanks very much.
Thank you. So I have missed Libuani Lifika from the National Department of Health. Maybe we can give it to the response and the reflection. Libuani?
Good afternoon, everyone. Thank you for this opportunity.
First off, I'd like to acknowledge the shortfalls we have noted, the areas of improvement that are needed from our side. And currently, we are doing sensitization work in the clinics. And also to highlight that we encourage provinces to always order stock enough. They should also order buffer stock in terms of condoms and lubricants. Lubricants are available from the government. They are here in the current tender. The condoms and lubricants are there. So the provinces, they just have to make sure that they order stock in time and they always have buffer stock to avoid stock outs. And I also noted people were saying that they can't, some of them are shy to collect the condoms in front of the security guards or in front of the nurses. So we just like to encourage people to, especially the facilities, to place the condom cans inside the toilets so that people will be free enough to actually take the condoms or lubricants not in the sight of the public. And also, we are currently acknowledging all the challenges that have been highlighted, and we are also doing work in terms of PrEP and PEP, in terms of sensitization. And our facilities, as national, we train all the provincial coordinators. We also train the RTC offices on the different messaging and communication channels that have to be followed. So as a result, I heard there's a participant that mentioned issue of breakage of condom. So in that instance, we also encourage the public that if they don't know to use the condom correctly or accurately, they must engage with the facility nurse who's working at the clinic so that they can demonstrate for them how to properly use a condom. Because a condom can only break if it's not used accurately. And also, colleagues, we also have what we call a condom communication strategy that we are rolling out in all the provinces. The condom communication strategy has got different messaging for different age groups. So this document actually helps the healthcare provider in terms of how to correctly communicate with the different age groups. As it was highlighted, some people were saying that it's better for a key population to be at each facility or to communicate challenges when they are there at the. So this document is actually a good document that it can actually that highlights the issues of sex in terms of also condom use, how to address it, because we know that it won't be possible or is currently not in place that we've got all the key population in the facilities, but the document can also assist in terms of how the healthcare providers can communicate to different age groups when it comes to issues of sex.
It seems like we have lost Ulivwani. Just hoping that she will manage to get back to us soon. So without wasting any time, because we have lost her, I think now let's give it to the Global Fund, Maxim, who's the country director, who will respond online.
Thank you, Chair. Can you hear me? I'm
Yes.
audible?
Yes, you're audible.
Thank you. So, first of all, our congratulations on the successful report launch, and thanks for the opportunity to be part of this dialogue. The findings as well as stories are extremely insightful. And we appreciate all the implementers for your hard work in compiling, analyzing, and sharing this important quantitative analytics, but also qualitative stories are very important to support numbers. Overall, we are in full support with the report recommendations. We, together with CCM, are working hard to ensure that some of these recommendations are implemented. And as many of you are aware, we are moving into the next cycle of Global Fund grants starting from April this year. And as proposed by the CCM, we will enable that Global Fund supported implementers moving forward in the new grants offer hormonal replacement therapy as part of direct core service instead of referrals as in the current phase. And we are going to build on the existing experience we have as part of the transgender program implemented by our principal recipient, Beyond Zero. We will also work together with CCM to make a deliberate attempt to strengthen regulatory system capacity, for instance, to support and work with National Department of Health and other stakeholders to support the process of registration and scale up of OST, as well as other prevention new products. We are very concerned about some of the numbers and stories in terms of the staff attitudes, discriminatory practices, and refusal of treatment for key populations at public health facilities. We are working and have been working with national stakeholders to address stigma and discrimination in all settings. We have increased our investment in training programs, integrated with existing training for health workers to ensure sustainability, and invest in know your rights activities among PLHIV, TB, and key populations. Of course, complementary to all other efforts in the country. It is evident through this report that we need to do better on this. So through the next cycle of grants, we'll be aiming to scale up key population sensitization and training of health providers at facilities. And moreover, again, some of you may have heard that we have agreed with PEPFAR, UNAIDS on focal country collaborations in a number of priority countries to intensify the collective efforts to make facility-based services inclusive of those in need. And on some specific recommendations, improving drop-in centers and mobile clinic services. We commit to working together with CCM and of course our principal recipients. So in the next cycle of grants, as per the recommendations and directions from the CCM, we will be investing in community-led monitoring efforts in, again, complementary manner to all the existing work on the ground, to provide direct independent feedback on service quality and in strengthening platforms at provincial, district, and as well as national levels that bring service providers and communities together. This would help to hold service community providers accountable. We also intend to work together with implementers and the guidance of CCM to expand service coverage through scale up of drop-in centers, and in a particular district introduce one-stop shop, learning from available experience in the region and outside. In the implementation of the next cycle of grants, we will also support our implementers to review how they utilize drop-in centers through, for example, review of SOPs, technical guidance, etc., to ensure that they maximize the safe spaces to promote health, well-being, and prevention, testing, treatment literacy among their clients. So to conclude, we will continue to work with the Ritshidze team to monitor progress in the areas highlighted today. and would welcome any feedback and suggestions on how we can better contribute towards comprehensive, KP-driven HIV prevention response in South Africa. Thank you, colleagues. Back to you, Chair.
Thank you very much, Comrade Maxim, and thank you very much for everyone who's been patient with us till now. We also like to thank the Department of Health for responding, but I'm a bit disappointed because sometimes it feels like people are not listening to what we are saying. People are complaining about the attitude of staff. And when I'm unable to use a condom, I'm also referred to the very same nurse who I'm scared to go to, who I fear that this nurse, the very same nurse will discriminate me. So I think from now on, especially from the Department of Health, you need to listen. And you need to also listen to our recommendations, because you can't send a person to the very same person that the person is scared of, and the very same person that is homophobic, that the very same person that is discriminating. That is a very disappointment. So, but then I think, and we believe that after this report and the reflections and the recommendation will be also discussed, will be given a date soon from all our partners to engage more on the report. We are expecting that from the Global Fund, the CCM, the Global Fund and PEPFAR and the National Department of Health. Luckily is that people living with HIV are also represented at the CCM, and we will watch closely on the on your responses, Comrade Maxim, to say CCM follows what the Global Fund has committed, especially in terms of key populations. So without wasting any time now, colleagues and comrades, I would like to thank you very much for availing yourselves, those who are online, for joining us, and be patient with us. We know how tiring it is to sit on a computer or on the phone for more than 3 hours, an hour, sometimes it feels so much. But then you were patient with us, you are here with us, and those who are with us physically, we know that some of you had to leave home from yesterday, some they traveled overnight to be here. Thank you very much, comrades and colleagues. We really appreciate your presence here. In that note, let me also thank my panelists here for the good work, and those who are working behind the scenes, because there are a lot of people who had sleepless nights preparing for this event. Thank you very much, colleagues and comrades. Meeting adjourned. Thank you.
I wanna dance by water beneath the Mexican sky, drink some margaritas by swinging blue lights, listen to the mariachi play at midnight.